We're running a bit late, so I'll try to get things started. Just to welcome everyone to our Paediatric Airway Symposium. And I'll introduce the speakers as we go through them. Our first speaker is Professor Cheyenne from Perth in Australia. He has an incredible academic record. But I actually would like to introduce him more from a humanitarian perspective. He's come out to us twice to help us here in Durban at his own cost and his own need. And very grateful for that kind of support. I just think it speaks to the type of person that he is, and we're very grateful for that. But that comes with a wealth of knowledge and experience, and we really look forward to your talk this morning. Thank you very much.
Thank you very much, Warren, for your kind words and the connection to speak to you today. Just the AV guys, shall I advance on your computer or my computer? My computer, okay. Maybe I need the mic over this way. Sorry, you've just been watching a video of sort of a sky view of the Children's Hospital in Perth, which is the very green building. Very green building. Next to it is the adult hospital and the whole research institute. And on the other side of the road is Kings Park, which is a 1,000-acre park in the middle of the city. And the hospital was built, completed in 2018, and it's full of playgrounds and all kinds of kid-friendly stuff. So I've been asked to talk to you about assessing the neonatal airway and managing the neonatal airway, but it'll spread into the whole pediatric airway as well. We're going to talk about the nasal things like piriform makrotestinosis, choanal atresia, etc., pathology in the supraglottis or the tongue base, the glottis, the subglottis, and the trachea. The most common airway thing we see is pathology. We see laryngomalacia, inspiratory stridor, sometimes misdiagnosed as bronchiolitis and all kinds of stuff. And in general, it's pretty obvious. And when you do a nasendoscopy, we see the arytenoids flopping, which is the most common abnormality we see. We also see shortening of the epiglottic folds and sometimes an omega-shaped epiglottis, which can also be floppy and cause airway obstruction. They usually present with symptoms of feeding difficulty, but can also present with a sleep apnea picture. So when assessing the neonatal airway, it's a pity we can't make the slide in here any bigger. Is there any way you can zoom in on that so that the slide becomes the main screen rather than the whole Zoom screen? That'll have to be something from your end. So the critical things to look at when assessing an neonatal airway is it stridor or stertal? Because that means completely different things. If it's stridor, it's a laryngeal or tracheal pathology, whereas if it's stertal, it's nasopharyngeal or pharyngeal. So, and then if it's stridor, is it inspiratory, biphasic, or expiratory? And just by thinking about those fundamental principles, you can then work out where the pathology is. So if it's stertal, it's a nasal sound or the pharyngeal sound, and you're thinking nasal obstruction. And one of the things with nasal obstruction is that it does cause a lot of feeding difficulty, but often the nasal obstruction or the obstruction to the airway gets better when the child is crying because they start breathing through their mouth, right? And so they're some of the critical things to look at when in the history and examination findings. With stridor, if it's inspiratory, you know it's above the vocal folds. If it's biphasic, it's glottic, so vocal folds or subglottis, or if it's expiratory, then it's usually in the intrathoracic trachea. And if you think about the physiology of respiration, you realize on expiration, the luminal pressure within the trachea is less than the extraluminal pressure, causing the expiration of air. And so you get collapse of any floppiness in the trachea on expiration. So that's why you get expiratory stridor if it's intrathoracic tracheal obstruction. And the way you investigate things is very different as well. So if it's inspiratory, you can usually make a diagnosis on using a nasendoscope. If it's biphasic, you may see some pathology at the glottis, but you may not be able to see anything in the subglottis. And if it's expiratory, then you need either a bronchoscopy or some kind of imaging like a CT scan of the chest. And then the nasal symptoms can be, nasal pathologies can be identified on nasal examination or on fiber optic nasendoscopy. So the investigations in general, all of these things end up having a nasendoscopy. Some of them, like if it's inspiratory strata, you might monitor their weight, or you may get a sleep study if they're presenting with sleep symptoms. If it's laryngeal, then usually a microlaryngoscopy to make a diagnosis. And if it's expiratory, then you often need a bronchoscopy and a CT, as we were talking about. So these are the questions we ask in the history, as I've been talking about. Other things you want to know, are they aphonic when they cry? So that might imply something like a laryngeal web or a laryngeal atresia. Are they hoarse when they cry, which may imply some inflammation of the vocal folds, which may be caused by reflux or other pathologies? Do they have a cough when they feed, which may suggest some discontinuity between the esophagus and trachea, like a tracheoesophageal fistula or a laryngeal cleft? So they're the kind of things we talk about in the history. And then when you examine the patient, you know, we start off looking at the head and neck in general. Do they have any dysmorphic features? Do they have a small mandible? Do they have a narrow maxilla? Do they have any hemangiomas in the face, which may suggest a subglottic hemangioma? Are they breathing through the mouth? Are they drooling? And then you can examine for the stridor. Is it inspiratory, expiratory, or biphasic? And then you can look for signs of respiratory distress, intercostal indrawing, the tracheal tug, and suprasternal recession. And the critical thing that we do, obviously, is to monitor their weight. All pediatric doctors, no matter what their specialty, should be obsessed with patients' weight, because babies aren't growing, usually have something going on. And you can see this is a kid who was failing to thrive, crossing centile lines, and then the arrow, which is when we intervene with the surgery, you can see what happens when the baby can breathe, they can grow. So the things we talked about are the weight chart, sleep studies sometimes, if they've got sleep symptoms, radiology. And then what do we do when we investigate them? We use a combination of Hopkins rod, a rigid telescopic bronchoscopic examination of the larynx and trachea, and fiber optics. And the advantages of each are that I'm going to flash forward that one. But that the flexible bronchoscope gives you better view of dynamic airway obstruction, so malicious, and something that's floppy is best seen with the patient breathing spontaneously with the fiber optic scope, whereas fixed obstructions like a subglottic stenosis or a tracheal stenosis are often best investigated with a rigid telescope. So in summary, the history and examination are critical. In assessing the severity, we would look at the weight chart and the sleep study, and the investigations we've talked about: bronchoscopy, nasendoscopy, etc. So, so one of the indications for surgery, the most common indication for surgery in laryngomalacia is failure to thrive. But airway obstruction causing OSA is not an insignificant cause or a result of laryngomalacia. And this is a paper we published back in 2009, where we actually looked at a whole bunch of kids who presented with laryngomalacia, but the sleep apnea variant of laryngomalacia, who we identified on a sleep study, and we fixed with supraglottaloplasty. Our technique is use cold steel. We don't use any lasers or anything else because of increased risk of scarring, and supraglottic scarring is a problem. We normally send the kid to ICU, and now we're down to like 6 weeks. That was 3 months, as used to be our previous paradigm. And we don't intubate the patient afterwards. They just go there breathing spontaneously. They normally spend, normally now they go to the HDU, not even the ICU. They spend about 6 hours in the HDU. Being observed, and if they're good, then they go to the ward afterwards. So pretty much the majority of kids will end up on the ward within 12 hours of having their surgery. They usually have a speech pathologist visit them the next day to reassess their feeding. They may have some pain that can affect their feeding. They may have some aspiration that's often temporary after you've had a supraglottaloplasty. So they modify the diet using thickeners, etc. And then they get discharged home, usually within 24 hours. So in the supraglottal, so I'm going to go down anatomically in the different pathologies. This is a thyroglossal duct cyst. You can see that big lump. and then it's causing sort of secondary laryngomalacia. And this kid actually was diagnosed initially by our registrar with laryngomalacia because the epiglottis was so floppy. But what they missed was the thyroglossal duct cyst, which you can kind of get a little bit of a view of right there, causing the epiglottis to prolapse down. So don't forget secondary laryngomalacia, which can be due to rare things like a thyroglossal duct cyst or a lingual thyroid gland, and sometimes follicular cysts, which can be missed if you're just purely focusing on the larynx. So the next next cause of airway obstruction that we see would be some form of craniofacial syndrome. The most common one in our practice is the Raban sequence, clear Raban syndrome. They can have airway obstruction secondary, not just to the mandible being small and glossoptosis, the tongue being far back, but that can sometimes cause a secondary laryngomalacia as well. So you get sort of laryngomalacia related to the glossoptosis. Some of the other symptoms, some of the other syndromes are here listed. And the other things that we see are, if you've got, I guess, a tongue that's getting in the way, it can be due to a small jaw or a big tongue. So the big tongues we see in Beckman-Wiedemann syndrome and Down syndrome. And the two different problems, the retrognathia gets managed quite differently to macroglossia, especially when it comes to surgery. So when we're looking at airway compromise in the infant, I've talked about this just a bit earlier, but if you're looking for a dynamic problem, you want the patient awake, or if they're under a general anesthetic, very lightly sedated and breathing spontaneously. So your fiber optic scope can give you some idea of what's floppy. Once you start using rigid telescopes or a rigid bronchoscope, then you miss some of the floppiness, and you're more likely to only pick up structural problems, which are the fixed airway obstructions, which are often better seen with a rigid telescope or bronchoscope. So the nasal things that we see, rare but not insignificant, the things called nasal lacrimal duct cysts. I usually manage them just in the clinic, but you can see that's the inferior turbinate right here, and then you've got the cyst here. And what happens is that it's an interesting thing that, so when the baby cries, sometimes the airway obstruction gets worse because the cyst gets full of tears and then can occlude the nasal airway. We published a paper on a series of our patients who had nasal lacrimal duct cysts, and essentially they're pretty easy. You just spray some lignocaine with lignocaine with phenylephrine in the nose, causes some decongestion. And I normally get the otologist in the room will hate to hear this, but I get the cupped forceps from the grommet tray, and usually just and I get a whole lot of pus and tears that come out, and 90% plus have success with just doing that. Our ophthalmologists sometimes get very excited and they put in Crawford tubes and all that kind of stuff, but really, I don't think you need anything fancy apart from a little marsupialization of the cyst. The other nasal problem we see is piriform macular stenosis. It's part of the holoprosencephaly spectrum, and it's due to narrowing of the piriform aperture, as you can see here. We've done quite a bit of work on piriform macular stenosis over the years, and one of our first papers, which is here, essentially looked at the patients who ended up needing some form of surgical intervention, and what we found was if they had a width of less than 5.7 millimeters at the nasal piriform aperture, they were much more likely to need surgical intervention, and we compared our series to a whole lot of patients in the literature, so looked at about 100 patients, and essentially found that 5.7 millimeters was a critical point at which almost everybody needed some kind of surgical intervention. In the past, I used to do this open operation where we made a sublabral incision, like here, lifted up the nasal mucosa and the pharyngeal mucosa, oral cavity mucosa, exposed the piriform aperture, which is here, and used to drill it out. Then, more lately, couple of things we've found. One is that using balloon dilation alone, you can get a very good outcome. So now we just use balloon dilation alone in the majority of our patients. So put a balloon in without lifting the mucosa, just going straight through the nasal cavity, blowing it up. And the other thing we found was when we scanned all of these patients, we found not just the piriform aperture that was narrow, but the whole nasal cavity was narrow. So the balloon dilation was very helpful because it not only dilated the piriform aperture, it dilated the whole nasal cavity. And having looked at about a dozen or so of these patients, the majority of patients got away with just a single balloon dilation, one trip to theatre, balloon dilated. The patients who failed balloon dilation normally had some kind of craniofacial syndrome, and they usually needed more intervention, sometimes this kind of open repair. Looking at the nose as we go back, the other problem is choanal atresia. This can be either unilateral, as in this case, or bilateral, as in this case. This is the way we tend to approach choanal atresia. We use 120-degree scope in the oropharynx, looking back up at the choana. It's what we would consider the safest way to do this operation. In a neonate, it's very hard to get a telescope and an instrument down in a single nasal cavity. So this way, your telescope's in the nasopharynx and your instruments go in the nasal cavity. And usually, you just use a Hagar dilator to puncture through to open up the piriform aperture, and then either dilators, a drill, microdebrider, whatever it takes, depending on the thickness of the atresia, to open up the postnasal space. The other thing we do is we used to do a lot of stenting of these piriform of the choanal atresias, but now we don't tend to stent them. Although I must say, in the complicated charged baby, probably there is a role for stenting because they tend to have a much higher rate of restenosis. And for pretty much the critical thing about this operation is you need to get rid of the bone. So basically you get rid of all of that, the bone and soft tissue in the choana, and then you excise the posterior end of the bone and you convert your dual choana into one big choana, and then you're much less likely to get restenosis. Other things, this is a patient with a large glioma. This is a big glioma hanging down here, as you can see, in the nasopharynx, and the patient had to get intubated at birth. Here you can see this extra neural tissue hanging down the nasopharynx, and a patient who's a obligate nasal breather. They end up having lots of difficulty breathing, got intubated, and then we did actually very early on did a large procedure, a combination of a parapharyngeal approach and a fish type C, I think, to resect all of this glial tissue, and then patient got cannulated. The next, as we go down, the other thing we see apart is at the level of the glottis. We see things like webs. This is a patient who had a very thin laryngeal web, as you can see, without any obvious subglottic stenosis. And in this patient, we would consider, we'd call it a web. It's associated with velocardiofacial syndrome or 22q deletion syndrome. And in these thin webs, you can perform endoscopic surgery and place a little keel. Whereas in the thicker webs, like this one, we usually need, as you can see, this is quite a thick web, and this kid had velocardiofacial syndrome. Sorry, that video is not playing. And you can see how abnormal this larynx is. So that's the thyroid cartilage. That's a cricothyroid membrane. You can see it's this tiny, skinny little cricothyroid membrane. And that's then the cricoid cartilage, which is a very funny heart shape. And they've also got a tracheal stenosis at the first, second rings. So this is a part of the laryngeal atresia spectrum of pathologies. They don't respond very well to endoscopic treatment and usually need some kind of open surgical approach. And in this kid, I think we ended up doing a cricotracheal resection. But one of the problems when you've got pathology extending into the glottis, when you do a cricotracheal resection, which is where we resect part of the cricoid, we essentially had to do a slide of the trachea into the larynx. So it's got an extended cricotracheal resection. That's interesting for all the ENT surgeons in the room, but not so much for everybody else, I'm sure. Otherwise, the vocal cord palsy, the next most common thing that we would see, laryngomalacia being the most common, usually presents at a relatively young age, idiopathic being the most common. So unilateral vocal cord palsy is normally seen following cardiac surgery or tracheoesophageal fistula repair. Probably roughly 10% of each of those patients get a recurrent laryngeal nerve injury. And other things include intubation, trauma, neurovaricella, etc. This is a patient, a 4-year-old male who had a tracheostomy placed after he had bilateral vocal cord palsy following a top repair and cardiac surgery. He's actually, his dad's an ENT surgeon and a friend of mine. And he also had quite severe tracheomalacia, gastroesophageal reflux disease, had a tracheostomy, fundoplication, gastrostomy tube, etc. And you can see both his vocal cords are fixed. And he eventually came in to have a laryngotracheal reconstruction. Now, the bilateral cord palsies usually are not as unlucky as that. They can be idiopathic, being the most common. Other things are Chiari malformations, so that's why it's important to scan the brain. And we've also seen it following vincristine toxicity for the treatment of cancer. How do we investigate these patients? And there's a pharyngoscopy, an MRI scan, brain to mediastinum, microlaryngoscopy. It's important to do that because you want to work out if this is a fixed cord or a paralyzed cord. And there are two different problems, right? So a fixed vocal cord is due to either a pathology of the cricoarytenoid joint or posterior glottic stenosis, whereas a paralyzed cord is due to some kind of neurological problem. And you should manage them quite differently. A fixed cord due to CA joint fixation or posterior glottic stenosis is not going to get better over time. There's no point waiting until they're 24 months or 5 years before you do something definitive to fix them. You probably need to fix them early on. Whereas if you've got a paralyzed vocal cord, then you have the recommendation or the traditional recommendation of waiting to see if they have some form of natural resolution. Other things we do is evaluate swallow when you've got a vocal fold fixation, especially if it's unilateral, either video fluoroscopy or endoscopic evaluation of swallow. And in some of our patients, we do a laryngeal ultrasound. We find that's really useful in those patients who are hard to diagnose. Sometimes these little babies can be very hard to diagnose with cord palsy, especially if they've got some laryngomalacia and you can't get a good look at the cords whilst they're awake. And when you give them a general anesthetic, they sometimes get inability, they don't move their vocal folds because of the depth of the general anesthesia. And so an ultrasound whilst they're awake, this does take some expertise from your radiologist. In fact, one of our registrars is now doing a research project where she's actually doing the ultrasounds herself in conjunction with the radiologist to try and teach the ultrasound radiology skills to us. One of my other fun jobs is I'm an ENT surgeon at the Perth Zoo. Lots of primates that I manage, usually orangutans, chimpanzees, etc. This is a lemur, a Madagascar lemur. Most famous from the movie Madagascar. The guy was, you know, like, I want to move it, that guy. And they all get sinusitis, right? And probably because they're exposed to human beings who are coughing on them and stuff, but also because a lot of these primates are not indigenous to Australia, and they do eat and live on gum trees in Australia, eucalyptus trees, and they get a cryptococcus fungal sinusitis from which is in the trees. And so being precious, especially the orangutans at the Perth Zoo, who are one of the few places where because of masses of land clearing in Indonesia, Borneo specifically, where they have used to have a massive population of orangutans, gradually shrinking. So what happens is that they bring female orangutans from Borneo to Australia, and they then use them to breed orangutans, and then take the babies back to Borneo and rehabilitate them. But that makes the mums super important. All mums are important, obviously, but these orangutan mums are very important, and because they're essentially breeding machines. And so whenever they get any kind of sinus problems, in I go, and we do endoscopic sinus surgery usually, and it's been a really interesting part of my career to do endoscopic sinus surgery on orangutans and lemurs. The lemurs I can't actually do endoscopic sinus surgery on because they've got a very small nose. I mean, that lemur is 4 kilos and they've got this long snout, right? So traditional instruments don't work, and they usually have external, like a Caldwell Luck for their maxillary sinusitis and external ethmoidectomy. Anyway, skills that I don't really practice, you know, on human beings anymore. So back to the main game. Do we use EMGs? Very rarely do we use EMGs in investigating bilateral cord palsy. But it's certainly a good way of either predicting or making a diagnosis, or also predicting recovery and timing of surgical intervention. This is a child who was thought to have bilateral cord palsy, but actually had bilateral vocal fold fixation. I also had, so this mass there is a pannus formation in the cricoarytenoid joint. In fact, she also had an undiagnosed laryngeal cleft, and you can see subglottic stenosis as well. So in this patient, you know, she'd been waiting for years for this cord palsy to get better, and at the age of 6 came and saw me, and I was like, well, actually, you don't have a cord palsy, you've got fixed like a cricoarytenoid joint. So we ended up doing a LTR, we fixed the laryngeal cleft, and et cetera, et cetera. This is a bit of research I did as a fellow back in 2005, where we looked at a whole bunch of babies who'd been intubated for a period of time and then passed away. And what we found, and I was doing sections of the cricoarytenoid joint, and what I found was the longer they'd been intubated, the much more likely they were likely to have arthritis of the cricoarytenoid joint. And you can see in this baby, there's actually been dislocation of the cricoarytenoid joint, and this inflammatory pannus formation around the joint, which then would lead to fixation of the joint and then fixed vocal cords that may mimic cord palsy, but actually it's not cord palsy, it's a fixed joint. And there's no point waiting 12 months for this to recover, because it's never going to get better, and it just gets worse as it fibroses up. And so in these patients, you might think about doing some kind of surgical intervention earlier rather than later. Posterior glottic stenosis is commonly misdiagnosed as a kid who actually was diagnosed with bilateral cord palsy by, in fact, one of my colleagues. And then I think I ended up seeing them in clinic one time, and I was like, well, actually, no, this looks like a posterior glottic stenosis, and it's pretty obvious posterior glottic stenosis, as you can see. And so the posterior costal cartilage graft is very successful at managing posterior glottic stenosis, as it would be with cord fixation due to cricoarytenoid joint pathology. So the 3 questions when you've got a fixed vocal cord or a bilaterally paralyzed vocal cord: do you need a tracheostomy? If you have a tracheostomy, when do you give up waiting for recovery, and which operation do you perform? About half our patients with bilateral cord palsy end up needing a tracheostomy, but others can be managed with non-invasive ventilation. Who needs a trachea? The ones with severe airway obstruction, difficulty extubation, OSA, bad OSA, and failure to thrive. And the posterior costal cartilage graft, this is what we do. We take a bit of rib and then plug it into the back. We've done 4 of these this week, so nobody should be a stranger to it, unless you work in theatre, obviously, and I'm not a surgeon. And so this is kind of what it looks like. About a few months later, you've got the cords have been pulled apart. That's where the stenosis was, and that's the rib graft that we put in. That's nicely mucosalized and you know, wide open airway. So the management options for fixed vocal folds are endoscopic or open or re-innovation in a small percentage of patients. And really for us, the posterior costal cartilage graft, either placed endoscopically or open, is the main workhorse of managing this problem. That's a complex airway team. I think all of these patients should be managed by more than one specialty. So our complex airway team, that's actually only a small group, has ENT surgeons, speech pathologist, plastic surgeons, general surgeon, cardiothoracic surgeon, speech pathologists, dietitians, physiotherapists, social worker, and a whole bunch of specialty nurses. Because most of these patients who are complex with tracheostomies and gastrostomy tube, or gastroenterologists and pulmonologists, I forgot the pulmonologists, they're really important, respiratory physicians, they have multiple problems. It's not just their airway, they've got neurological issues, they've got social issues, they've got feeding issues, they've got weight gain issues, they've got parent problems, all that kind of stuff. So they have basically a whole family of people. We meet every second Friday morning for about an hour, and we basically do a virtual clinic, going through everybody's problems, come up with action plans together, and it saves patients coming to see all the different specialties over and over again. So essentially, the lead clinician would be, if it's an ENT surgeon, would probably see the patient in clinic. Sometimes you'd have 2 or 3 of the other people come to the clinic and join us, but they may not have to see the plastic surgeon and the cardiothoracic surgeon and everybody else separately, because we discuss everything together. It's the bane of our fellows' existence. They all complain about it. Rachel used to complain about it all the time, because it would take, you know, all week for her to put together all the information to present, because you have to get everybody's notes and everybody's opinions and put it all together, summarize it into a package, get their videos online and everything together. but it's so useful for the parents, and it's a great learning experience, because as a doctor who's learning, you get everybody's opinions, and then you come up with a management plan. So this is a kind of what I'd call an easy subglottic stenosis. This is a 28-weeker who was intubated briefly because they got some kind of viral illness, and essentially developed subglottic stenosis. Nice and clean, you know, clean vocal cords, no involvement of the posterior glottis, just a pure subglottic stenosis. We initially managed this with some balloon dilation, but you can see a pretty tight stenosis, came in extremis. Other things that we might see cysts, subglottic cysts, which we see in kids who are post-intubation. We actually looked at the main risk factor for subglottic cysts is the frequency of suction of the endotracheal tube. Probably unrelated to the frequency of suction, but probably related to the fact that every time you suction, you're mobilizing the tube and irritating the subglottis, or they've got another reason like reflux or some kind of inflammatory problem that's needing them to be suctioned all the time. The other point of this slide is we need to size the airway. Formal sizing of the airway is an important way of managing patients, because you can work out how bad things are. And the way we do it is we intubate them with the largest possible endotracheal tube that permits a leak, and that'll give you the size of the airway, and then you can use it to stage the patient's subglottic stenosis. We haven't had to do it very much this week because everybody's had like a 99% stenosis. But in general, if they've got a less than a 99% stenosis, you should size it formally with an endotracheal tube, and then use a Cotton-Meyer grading system to work out. So example, if you've got a 3-month-old baby and you can only fit a 2.5 millimeter endotracheal tube in, they've got like a 50% subglottic stenosis, which would give them a grade 2 subglottic stenosis based on the Cotton-Meyer grading scale. The risk factors for acquired subglottic stenosis is a paper that I did in conjunction with our neonatology team, and essentially we looked at what are the risk factors for developing a subglottic stenosis that's bad enough to need a tracheostomy or laryngotracheal reconstruction. And probably the biggest risk factor was the size of the endotracheal tube. So there's a thing called the Sherman ratio, which is the ratio of the endotracheal tube to the larynx, or to the duration of gestation. So if you have a 25-weeker and you put in a 3 millimeter endotracheal tube, the Sherman ratio is greater than 1, because it's 3 over 25, which is greater than 0.1. So that means your tube is relatively too big for the size of the larynx. And that is your biggest risk factor for developing a subglottic stenosis post-intubation. And one of the problems was we always used to intubate patients with non-cuff tubes and try and put a biggest tube in that would not permit a leak. And that has resulted in a change of our practice. Now we use cuffed tubes, low pressure cuff tubes, where we can use a smaller tube so there's less pressure at the glottis, and you use a cuff with regular pressure monitoring to stop the leak. And that has resulted in a massive reduction in the rates of subglottic stenosis in our institution. That's another study which I haven't quoted here. So subglottic stenosis can be congenital or acquired, and is usually diagnosed when the patient fails extubation. Traditionally, you did a tracheostomy or an open cricoid split. These days, we have all kinds of options, such as balloon dilation, which is a good temporizing maneuver. And in some patients with early subglottic stenosis, it actually may be curative, right? And when they've just purely got subglottic edema, you may be able to manage it with balloon dilation alone, with steroid injection, and then avert a subglottic stenosis. But once the subglottic stenosis is established, when you've got true scar formation, then it becomes more challenging. Actually, this video I just realized didn't play, but maybe it will play. No, but this is performing an endoscopic cricoid split. So that's the sickle knife on the anterior cricoid, and I've already done a posterior cricoid split here. And so if the balloon dilation alone doesn't work, we will bring them back and do an endoscopic cricoid split. Usually I do anterior and posterior, balloon dilate, intubate them with a tube for 5 to 7 days, and then a slightly bigger tube that they came with, kind of distract the cricoid, and then extubate them a week later back in theatre. And this is not unsuccessful, to be honest. It actually does work in those patients who initially failed a balloon dilation alone. It's less complicated than having any major surgery. It's good if you've got no heart or lung disease that's also going to compromise your ability to be extubated, if they're non-syndromic and not needing intubation and ventilation for other reasons like chronic lung disease. So the next option in a neonate who's got a subglottic stenosis, to try and avoid a tracheostomy, you can do a laryngotracheal reconstruction. Now, most of these patients will be under 6 months of age, and there have been a few papers. This is a paper from Sick Kids in Toronto. This is in Cincinnati, and I co-authored that paper. And this is from Perth. And what we were doing essentially was in kids down to 2.5 kilograms, we were using thyroid ALA, which you rarely use when I'm here because the stenosis is pretty bad and they're usually much older. Use a little bit of thyroid ALA, so it's no rib incision, it's purely a neck incision. You harvest the thyroid ALA as your augmentation. You make an anterior cricoid split and a posterior cricoid split, and then you just use the thyroid ALA as your augmentation tool to expand the subglottis and then avoid a tracheostomy. And it's been pretty successful in kids who've got good heart and lung disease, who've got just an isolated subglottic stenosis from intubation that's failed endoscopic treatment, to then do this endoscopic, this open laryngotracheal reconstruction using just the thyroid ALA graft. Pretty quick and easy operation, and usually in the right patient. So in all of these things, it's all about choosing the right patient. You can have pretty good outcomes. But the majority of our patients these days are not that simple. They usually have been intubated for a while. They come in and they've got a transglottic stenosis. You know, Durban's full of these patients with transglottic stenosis. So bilateral cord fixation. You can see this cord is massively swollen, and then they've got a 99% subglottic stenosis and fixed cricoarytenoid joints. In these patients, you're probably not going to try and fix them as a neonate. You're going to have to wait until they're a bit older, a bit bigger, weigh a bit more, and then perform a laryngotracheal reconstruction. And in these patients, we start looking at things like costal cartilage graft augmentation, which is essentially for the non-surgeons in this room, where we get some cartilage from the rib, and you can see this is the cartilage from the rib in the anterior subglottis, and then some cartilage in the posterior subglottis, and use that to reconstruct the larynx. And this is that patient whose image you saw before with the fixed cords and the bilateral and the high-grade subglottic stenosis. Still has a funny-looking vocal fold there, but essentially a patent airway. So it's done as a double stage, which means we leave the tracheostomy tube in and use a suprastomal stent above the tracheostomy tube. One of the side effects of doing that is you can sometimes get some granulation tissue forming at the distal end of the stent, between the stent and the tracheostomy tube, but that's pretty easily fixed endoscopically. So that's following a laryngotracheal reconstruction. The next operation along this algorithm of managing subglottic stenosis, if you're all still with me, is a cricotracheal resection. That's when you've got a high-grade subglottic stenosis or a grade 4 subglottic stenosis, which means there's no lumen at all, in which case we do what's called a PCTR, partial cricotracheal resection. We resect the anterior part of the cricoid and the stenotic bits of trachea, and we retain the posterior cricoid because the cricoarytenoid joint, which sits up there, needs to be preserved and needs something to sit on, and then we anastomose the trachea to the thyroid cartilage. One of the things about this is that it's a highly variable operation. It takes quite some experience, having done airway surgery, to get this one right. Have I run out of time yet? I have. Okay, I'm done. There's a whole lot more to talk about, and maybe we can do it some other time. Thank you very much.
You haven't run out of time. We just started a bit late.
Yeah.
So I apologise.
Oh, no problem.
Thank you. Sorry that we stopped you there. We just started a bit late, and we're hoping we'll make up a little bit of time later on and give you a chance to talk some more. I actually ask you a lot of questions. Our next speaker is an online speaker. He's actually talking to us from Europe. It's Dr. Kishore Sandhu, who heads up the airway unit at the Otolaryngology and Head and Neck Surgery unit in Lausanne University Hospital. He's published extensively in peer-reviewed international journals and has written several book chapters on pediatric and adult compromised airway. And he specializes in treatment of complex airway obstructions and laryngotracheal stenosis. I think what's really important is that he runs a phenomenal symposium, in which he brings together a lot of multiple disciplines, including ENT, anesthesia, ICU, and for this reason, it was actually what inspired trying to have a similar symposium here, where we bring together all the specialists. And he runs the London Laser Airway course in every year in September, just to let everyone know about that. So, but we just would like to thank you very much for offering up your time. I know he's also a bit short of time. He needs to be in theatre in the next hour. We're grateful for your time. Thanks, Brian.
Hello, do you hear me well?
Yes, we do.
Yeah, hi. Thank you so very much for this invitation. Lovely to see Shan. And, the whole idea of sort of discussing today is what we learned from our mistakes, going back and doing a pediatric tracheostomy. In my unit, in fact, we do both. We do adults as well as children. And we do have some experience in, having very bad tracheostomies in children. And, this is what I'm going to share with you in this presentation. So just give me a minute. Okay, so I need to. Okay, so today, in fact, the indications of doing a pediatric tracheostomy are basically three. You have an upper respiratory tract infection or an obstruction, typically related to a laryngotracheal stenosis that will include a bilateral vocal fold palsy, or sometimes a unilateral vocal fold palsy, an obstructive sleep apnea syndrome kind of narrowing, typically related to craniofacial narrowings and deformities, prolonged ventilatory dependence, typically related to cardiopulmonary disease and pulmonary toileting. So if you have patients with neurological impairments, laryngotracheoesophageal clefts or tracheoesophageal fistulas, these are the cases where one will require a tracheostomy. But overall, I think the number of tracheostomies have really, really decreased in my institution. And of course, the reasons are basically related to the use of non-invasive ventilation techniques, the CPAP and the BiPAPs. And it's true that all over the world, we hope that we have more and more people actually trained in using correctly the non-invasive ventilation techniques, and thereby reducing the number of tracheostomies, especially in children. This is the way as we see it in an Anglo-Saxon literature, how we do a tracheostomy. So basically, either we have a vertical or a horizontal incision in the neck, then we actually spread apart the neck prelaryngeal muscles. Then we actually do a isthmotomy, which actually exposes the trachea. And then the whole sort of conversation and the confusion controversy is going to be on the incision on the trachea itself. So either this could be a vertical incision, and by this, in fact, we are going through a couple of more rings. We then put some sutures on either side and then retract the trachea laterally and then insert the tracheostomy cannula. This is not the way we do our tracheostomies. Typically, we do our tracheostomies under general anesthesia, either with an endotracheal tube or a rigid bronchoscope or a laryngeal mask in place. In children, we have a lot of this baby fat, so we resect subcutaneous fat, and we usually do only one ring Biox flap. We'll see that a little bit later. We always use resorbable skin sutures around the stoma, and the idea is to mature the stoma immediately. So typically what we will do is we will have a one ring sort of Biox flap. This distance is equal to the outer diameter of the selected cannula plus 1. It shouldn't be too large, because if it is too large, then it is going to go much more laterally and it probably is going to transect the trachea, almost transect the trachea. If it is too small, then it is possible that, to insert the cannula or to reinsert the cannula sometimes in a accidental decannulation can get a little bit tricky. So your stoma size is something which is very critical, and that will depend upon how you have selected to make the incision in the trachea. This is the way we do our tracheostomy. We always have a kind of a matured tracheostoma at the end of it. This is during a cricotracheal resection, but it's just to sort of show you that we use resorbable sutures and then try to get the skin really in close contact with the edges of the tracheostoma itself. We find there are some advantages. The advantages are basically of a Bjork's flap and a stoma which is entirely matured are basically no risk of false passages. Probably there is limited or reduced subcutaneous emphysema, and probably there is less of suprastomal collapse and granuloma formation. But again, we need to really do some kind of dedicated studies to really prove this, that with a Bjork's flap, a single ring Bjork's flap, we probably have lesser complications. This is a kind of a quick reference guide that we use. And this is a kind of a classified card that all my residents will have in their pockets. And the idea is that basically you have an endotracheal tube size that we use, which is age appropriate. And then we actually have sort of, different sizes of the tracheostomy cannulas that actually we use in our patients, and what size is going to fit into which patient. This is what we get from this particular chart. This also corresponds to the size of a rigid bronchoscope, corresponding to a size of a flexible endoscope. So this actually gives a lot of information just by looking at this classified card. Just to give you an example, if you have a 2-year-old child who comes to you with a foreign body aspiration, then from this, you actually are able to find out what is the size of the rigid ventilating bronchoscope that one can choose. What is the flexible endoscope that one can choose? If the patient has to be intubated, what is the outer diameter of the endotracheal tube that can be used? And from here, you can actually select what size of tracheostomy cannulas can be used in that particular child. Of course, this was actually done for patients, for laryngotracheal stenosis surgery. And the cannulas that actually are seen in our institution are basically these 3 varieties. But of course, this card can be used in different ways that actually suits your institution. I think one of the things while we do a tracheostomy for an incipient laryngotracheal stenosis is the site of stenosis. I can tell you at least about 5 possibilities when you have to really decide what exactly is the site of doing a tracheostomy for different indications. Let's look at laryngotracheal stenosis, but while it is being formed or incipient stage. So if it is a situation like this, then try to put in your tracheostomy, as close to the stenosis, or at least leaving about 6 or 7 rings between the stenosis and your stoma itself. Why? Because by this possibility, you can go ahead and do a single stage procedure. And if you're doing, by keeping a couple of rings between the stenosis and your stoma, you can do a 2-stage procedure. But conventionally, if you put the tracheostomy between the second or up to the 4th tracheal rings, between the 2nd and the 4th tracheal rings, then what's happening is the 1st and the 2nd tracheal ring are lost. So we lose out on normal trachea. So what is now happening is that, we end up having less and or shorter trachea. So the whole idea is to try to save as much trachea, normal trachea as possible when you are doing a laryngotracheal stenosis surgery. If you already have a possibility in a patient where you have a stenosis or a tracheostomy already done, then you need to put your stoma or your tracheostomy cannula into the same site, because this is the way in which you will be able to save your normal trachea. If you have a stenosis which is much more lower down in the intrathoracic trachea, then there's no point in putting the tracheostomy higher up between the 2nd and 3rd rings. In this situation, then you have to take an incision much lower down, and then you have to put in the cannula in such a way that that bypasses your stenosis itself. So there are various ways of looking at putting the tracheostomy at the exact site, but that will depend upon what is the incidence or what is the reason or the indication of doing a stenosis. Remember that it is a potential site of stenosis, your tracheostomy, and your site of a tracheostomy should not affect your future airway corrective surgery and decannulation. So this is really critical, that you must remember the stoma itself is a site of stenosis, and the site should not be affecting your future treatment to achieve decannulation. Let's see the tracheal incision itself in some special cases. Now, if you have a patient with craniosynostosis, Down syndrome, etc., you probably might end up seeing something called as a shield trachea or a cartilage shield in the anterior part of the trachea. And in this kind of a situation, I would prefer doing a window, but with a matured stoma all around. If you have to do a tracheostomy in a patient with a circular ring trachea, I would prefer doing a vertical incision. And if you have absent or near absent tracheal rings, sometimes it can happen. In such situations, the ideal situation would be to have a long cannula that is going to send as much of the trachea for the collapsing trachea as possible. So this is the way in which you have to select the right incision on the trachea. What are those cases where you may end up having a tricky kind of a situation? So if you have a type 3, 4 laryngotracheal clefts, so if you have to do a tracheostomy in a situation like this, you better be careful because very quickly your lower part of the cannula is going to be into the bronchi. If you have a tracheoesophageal fistula or a pouch, so this is a tracheostomy which was done, and as we go lower down, this is where in fact a pouch or the diverticulum of the trachea that is secondary to a tracheoesophageal fistula surgery. So eventually this is a kind of a diverticular sort of opening, and it risks the lower end of the tracheostomy cannula to go into this pouch, and the patient risks being asphyxiated. When would you definitely not be doing a tracheostomy? Remember, if you have very, very exaggerated neurological conditions, remember that often the brain holds the key to all your interventions. So if you are dealing with someone who's extremely morbid, extreme neurological conditions, it is better to start thinking of end-of-life decisions. Tracheal agenesis itself, you don't have a larynx, you don't have a trachea. So in a situation like this, it is no point in putting in a tracheostomy in a very small, tiny sort of bit of trachea remaining. These kids have a very little existence of life, and these are the cases where you don't want to increase problems for the child, problems for the family, and problems for yourself. Always anticipate a difficult tracheostomy. Cystic fibroma, one doesn't need to really think too much, you are going to have a problem. But look at this 15-year-old osteogenic imperfecta child who already has had a spine surgery in the past, and in fact now has been referred to us for doing a second surgery or a second tracheostomy. These are the cases where you will have, in fact, this patient had to have a C13 stabilization surgery, and it was quite tricky to sort of, get the endotracheal tube so as to sort of, do your tracheostomy. So we had to sort of, get the endotracheal tube, sort of impact it in a flexible endoscope, and then actually manipulate the mandible, manipulate the airway in such a way that you're able to get into the right space so as to get the trachea, and then do your tracheostomy. The tracheostomy itself, we use elastoplast to sort of, stabilize the mandible because these are the cases which can get a little bit tricky. So anticipating possible problems is something which is very, very critical. What happens later on after you've already done a tracheostomy? So this is a 14-year-old boy, achondroplasic. Again, the same story, that spine had to be fixed. And it was very tricky to decide the site of the tracheostomy or the tracheostomy cannula itself. So sometimes a Portex blue line endotracheal tube can be used. It can be sort of cut in such a way that the lower tip can be adjusted and not going selectively to any of the bronchi. A safety pin can be inserted, and then in fact the sort of Velcro sutures Velcro material can be used so as to fix it around the cannula. We do have a large referral of patients coming into our country, and of course I travel into different parts of the world to do surgeries as well. So this actually adds on to the experience in these kind of very difficult patients with tracheostomies. Let's look at the complications. So in the first post-operative week, typically the complications are related to technical errors or a poor tracheostomy care. And what will we see? There could be bleeding, there could be accidental decannulation, displacement, and then you had to recannulate the patient, mucus plugging of the cannula itself, pneumothoraces, pneumomediastinums, local infections, etc. What about late complications? We're looking at suprastomal collapses, granulomas. All these things we will see with certain examples. So let's look at the cannula-related stenosis itself. So in fact, there are 4 sites when you have a cannula going in, remember the cannula has got a convexity. So you could land up having a suprastromal granuloma with a suprastromal collapse and a stenosis. The cuff itself is a site of stenosis, so you could have problems anteriorly or you could have problems posteriorly, and then you have the lower tip of the cannula, which in turn can cause granulations and stenosis. Suprastromal collapse and granuloma. Typically, an A-frame deformity, again, can happen at the site of the stenosis. We will see with some examples a little bit later. This is a tip of the cannula lesion, which is much more lower down into the trachea. And this granuloma itself can go into a stenosis, and which in turn can get a little bit tricky because now you have a tracheostomy, which is now need to sort of go beyond this distal stenosis. So that's where, in fact, the site of maybe the stenosis is important. But apart from that, to avoid these stenosis and avoid these complications is even more important. If you do have granulations itself, it's very easy to treat. You don't really require a lot of these very fancy instruments. You just require cold steel instruments that you can find in your microlaryngoscopy instruments. So you just have to remove the infected granulation tissue. Bipolar coagulation works very well. Gentamicin corticosteroid ointment needs to be applied in that particular area. So you could even use some topical corticosteroids, and you need to really have a good, clean tracheostomy cannula in place. Suprastromal granuloma and collapse itself is seen very often in infants and small children. And typically, this suprastromal collapse may remain asymptomatic until the capping trials start, when we are actually looking at decannulations. And of course, as we saw earlier, it could only partially be avoided, but need to be confirmed if we are able to do a maturation at the time when we do a tracheostomy itself. So this is something that you must have seen in your practice as well, where you do have these unsightly stomas, or you could have the cannula itself, which actually is sort of keys wiring, and that itself, in fact, is going to increase the damage onto the trachea itself. So again, we go back to the original, the incision on the trachea itself. If it is a vertical incision, probably we are going to go through many more rings as against a Biot's flap, which probably is going to limit the number of damage that is going to happen. The cheese wiring itself can lead to sort of false passages. So in fact, this is a kind of a stomal cleft, and actually the tracheostomy actually cannula is going much above it. And if you do not know, or if you're not anticipated a problem in this situation, you may lead to false passages. So we didn't really have any problems in this patient, but there was in fact a subcutaneous cleft on the outside, but this needs to be anticipated when you actually go down and recannulate sometimes in this patient. Sometimes what may happen is you may have a tracheostomy cannula, you may have granulations going all around, in front, at the back, and then these granulations actually meet each other, which in turn is going to divide the trachea into two tracheas, one in front, one at the back. And this is what actually we see here, that fortunately, in fact, we were able to identify this problem much earlier. But if the patient comes to you much later, then you may already have a two-human trachea, which needs a proper treatment. And the treatment would typically be, of course, take care of the hygiene around the tracheostoma. You need to actually divide those sort of edges of the two parts coming from either side. You must apply corticosteroid locally. And then it is possible that instead of having a convex sort of tracheostomy cannula, you may start thinking in terms of temporarily stenting him with a T-tube in place. Because what you want is the skin and the tracheal sort of edges need to be at right angles to your T-tube. And this is the only way in which you can treat this difficult problem. The cannula in front can go into this big vessels. So a tracheoinnominate fistulization can happen, or posteriorly it might actually create a tracheoesophageal fistula. And the risk factors typically are low tracheostomies, gradual. What happens is that you do have this sort of tubes which are attached to the ventilators, and that itself is going to pull it down. So this adds on to the risk factors, and when you have an inappropriate cannula trachea access, typically seen in very obese patients, spine injuries, or when they are fixed, kyphotic patients. So in these patients, you need to be a little bit more careful. This is a child who is a known case of Pompey's disease, a glycogen storage disease. And in fact, you can see here that the cannula is pulsating. When we go lower now, the tip of the cannula actually is showing these granulation tissue. The child started getting the sentinel bleeds, and this was in fact an indication to go in very quickly and sort of treat this surgically and to prevent in fact a very catastrophic kind of a situation. And remember, to avoid a tracheo-innominate fistula, you need to really anticipate which are the patients which probably might require or go into this kind of a situation. So it's always better avoid a situation like this, and that can happen only when you have anticipated, really studied your patient correctly, and then actually, you're trying to avoid the situation. You could eventually think in terms of using hymas. You have a lot of these tissues in the mediastinum. You could use local muscles. You could interpose these tissues between your tracheostomy and these big vessels. So you need to really anticipate not only the patient, but also what your tracheostomy can give rise to in the future to this difficult condition. A tracheoesophageal fistula typically happens when you have the tip of the cannula or the cuff or the cannula itself, which is causing pressure decubitus on the posterior tracheal wall. Now you could imagine that if you have a nasogastric tube, or if you have a sort of a spine sort of condition, so it would only mean that the posterior membranous trachea is going to be squeezed between two very hard structures, and this itself is going to be a problematic. So typically for a TOF, the predisposing factors are large for age cannula, incorrect fixation or inflation of the cuff, vascular compromise, again, inadequate care of the tracheostomy, chronic steroid use. And as can be seen here, in fact, you can see that this is the site of the tracheostomy. And in fact, when we go down, this is the area of the tracheoesophageal fistula. And as we really go down, we can see saliva in the distal trachea and in the bronchi. So you have a lot of this sort of aspirated saliva in the lower airway. What are the most decannulation complications? Meaning that you have now gone ahead with the decannulation. The decannulation has been done. The stoma is completely closed. The outer hole is completely closed, and then you have an A-frame deformity. What it means is that you have this sort of side of the stoma, which now is going to act like a fulcrum. And around this fulcrum, every time the patient is going to create certain pressure changes, the lateral edges of the cartilage of the trachea is going to close down, is going to get a kind of an A-frame deformity. So you can see two glottic sort of, situations. You have a lower glottis, actually, which is a pseudoglottis, which is created by the two sort of fractured parts of the tracheal cartilage. And in fact, this is the true glottis. So this is an A-frame deformity. Typically in children, they may remain asymptomatic. When we actually start going ahead and doing a decannulation, that's the time they really present to us. And in adults, basically, they present to us with a fixed stenosis sometimes. And this may take a little bit of time. This may take a little bit of symptoms. This may take a couple of years to really get symptomatic. A lot of COVID patients today, adult COVID patients, pediatric COVID patients who had a tracheostomy do have these problems because it is possible that the tracheostomy was done in emergency. A lot of trauma was caused during the procedure itself, and this in turn has given rise to this problem. So again, the same story that you have this dynamic collapse, and then the only thing that we did is did a short segment tracheal resection and anastomosis, and within a couple of days the patient was absolutely fine. So you need to anticipate a problem. Of course, there are solutions to it, but if you can avoid a problem, it's always very good. And then if you have a situation where a resection has already been done, you do have a shorter trachea, and then you have a dynamic collapse of the tracheostomy itself, you can actually fix that by using non-resorbable, biodegradable, sort of these PDS plates polydioxanone plates. And by that, actually, you can fix the stoma itself. So this is, in fact, a child who was referred to us from Hungary with the same problem. So this is preoperative, and this is after fixation, stabilization of the trachea. Remember, tracheostomy is a site of infection, and you want to really avoid any kind of problems or pulmonary complications. So they all need to have an aspirate taken the moment they arrive into the hospital. So just to conclude, that remember, there is a certain mortality which is associated with the tracheostomy. Either it could be related to an accidental decannulation or plugging of the tracheostomy. I have had 3 children at home dying because of a tracheostomy. Remember that you need to really lower down the complications, and this happens only by anticipation, prompt diagnosis and management. Technical details when you do a tracheostomy are critical. Nursing is important. And when you're doing a tracheostomy, remember there is a significant role of parents and nursing at home that will be really important. And they really need to be given support, the parents, when a new tracheostomy has been done. Thank you so very much. Adila, I don't know, should I continue, or are there any questions, burning questions in the audience, which we can take? And how should we plan this? I'm just going to sort of stop sharing my screen, and I'm there with you guys now. Lovely to see you guys.
Thank you very much. So that's brilliant. I think that because you're going to be going to theatre later, we would rather take questions now.
Yeah, sure.
That's all.
Sure.
There's a question.
No, I was just saying hi.
You're saying hi. Perhaps one of the questions from my side, Kishore, thank you very much for joining us. I just have a question in terms of the plan with the children. What is your experience in terms of failure to decannulate or persistent fistula afterwards?
Oh, you're talking about the tracheocutaneous fistula?
Yes.
Okay, so they just need to sort of be closed. If there is a persistent fistula, tracheocutaneous fistula, we intubate them. I take a horizontal incision, an elliptical incision around the stoma. We actually sort of mobilize, try to be as close to the trachea as possible. Expose the trachea circumferentially, and then in fact, this whole tract, the whole trajectory of the tracheostoma is removed. And then eventually you'll end up having a kind of a hole in front of the trachea. And then in those cases, we just put sort of, 2 or 3 craniocaudal white krill sutures and just close them. We will then use, local sort of, prelaryngeal muscles. They are going to be sort of sutured over this fistula. Thyroid gland is going to be again resutured. We will try and see whether there is any kind of leak, air leaking. So in fact, the endotracheal tube cuff is going to be deflated. We give a Valsalva by closing the nose and the mouth of the patient during the surgery. See whether there is any kind of air leakage in the wound area. Put in a small easy flow or a Penrose drain and close it. And that's it. Provided the area of the tracheostomy site itself is not a source of stenosis. I'm talking about a dynamic collapse. Because if there is a dynamic collapse, then it requires a segmental resection and anastomosis.
Thank you. Any other questions? Yes.
Do you use coablation for suprastomal granulation?
Do you use coablation for suprastomal granulation?
Yeah, I think there are various ways of managing it. I'm sure there's coablation. Now again, remember that really depends upon what is the age of the patient. So I think coablation in a larger patient, a larger or an older kid or adults, I think can work. But smaller the kids, more are the problems, more constricted is the area. Really depends upon, you can even use a laser, you can use cold instruments, you can use whatever you want. Finally, these are all tools. If you're able to handle them correctly, if you're able to avoid collateral damage, and if you're able to anticipate already that your actions, what are the end results? So if you're able to do that, I think, you can use coablation, you can use, just local cautery, you can use cold instruments, you can use whatever you want. There's absolutely no problem.
Does your Bjork flap reduce the incidence of suprastromal collapse?
Look, Bjork's flap is only a way in which you're trying to create a stoma, anticipating what can go wrong with the vertical dissection. Can it avoid? I think one way of avoiding it is really try to get the skin in contact with the cartilage edge. The moment you have the cartilage which is going to get exposed, it will granulate. There will be infection locally. Infection means inflammation and granulation tissue. So I think these small minor details are really, really critical. What I think I tell my colleagues is, my younger colleagues is that don't treat tracheostomy as a very benign, tracheostomy is required, just go ahead and do it. No, I think this needs to stop. Really, it's really a source of stenosis in the future. It's a source of problems for us, for the entire medical and the nursing team. And I think it needs to be really given a lot of importance. A lot of sources of future stenosis are going to be related to a bad tracheostomy. So this is something which needs to be educated, which needs to be educated amongst the nurses and the doctors and, different specialties. So different specialties do these kind of surgeries, the tracheostomy, so they need to understand the nuances, they need to understand what can go wrong.
One more question.
How do you do the Bjork flap? Is the flap itself stitched to the skin?
Could you repeat that? I didn't really get that question.
The Bjork flap.
Yeah.
How do you said you do a skin muco?
Yeah, I mean, you just have a flap, which is, you just have to take a vicryl suture or any resorbable sutures. We always use vicryl because they're easy to handle. And from the skin going into the Bjork's flap. And in fact, as I said, it's a kind of a maturation done all around the stoma. So just like you do a total laryngectomy. So a total laryngectomy, you sort of mature the end stoma. So it's a little bit similar to that. The only difference is you're trying to reduce the trauma on the anterior tracheal wall.
And I think we'll move on to your next talk, if that's okay, Rob.
Right.
The
Start
second talk.
sharing now.
Great, thanks. So the next talk will be on posterior glottic stenosis.
I think Sean has already touched upon it, so I'm not sure whether, how much more I can add on. But do you see the screen now?
Yes, you can go full screen, Prof.
Okay, so you have full screen on your side and you hear me well?
Not yet.
Okay. Okay, you tell me when I can start.
You can start. You just go to full screen.
Oh, I'm already on full screen.
We can't see it on our side.
No,
You
I
can see
think
the slideshow.
You need to select your slide. Unfortunately, we're seeing all the slides on one at the moment. You need to
Okay, hang on.
select.
Okay, then I'll have to restart it again. 1 second. So let me just see it. Okay, so this is full screen now.
Can you select slideshow?
Yeah.
There we go.
Stop. Speak again.
I will have to. I don't know. From my side, in fact, I'm on full screen. 1 second. Let me just stop this entirely. Just give me a minute.
I think it was fine. Just when you select slideshow, there's a specific function.
Sure, I understand. Give me a minute. Okay, and let me go on to Zoom. Okay, 1 second. Actually, okay, and now I cannot go on full screen from my side. I don't know why.
That's fine, just push slideshow,
What about what? How about it now?
display settings.
I'm on full screen now.
It's fine, it's still on present.
Okay, fine.
Thank
Yeah,
you.
you're on the screen, that's fine.
You guys are on full screen as well?
Yes, Prof, you can continue.
All right, okay. So posterior glottic stenosis, typically, I mean, you are looking at a band of cicatricial tissue between the two arytenoid cartilages, between the two vocal processes of the arytenoid cartilages. So this, in fact, has been classified by the Bogdasarian classification as type 1. But in that, in fact, the posterior part of the cicatricial stenosis or the posterior commissure mucosa is intact. In type 2, you do have this sort of, very thick band of cicatricial tissue between the two arytenoid cartilages, and that actually goes behind, and even the posterior glottic mucosa is cicatricial. So this is type 2. And when you have this sort of cicatricial band, which is going into one of the cricoarytenoid joints that causes ankylosis on one side, it is type 3. And when it goes on both sides, it is bilateral cricoarytenoid ankylosis, type 4. And typical causes would be intubation, neck trauma, autoimmune conditions, tumors, radiotherapy. Now we're looking at the posterior glottic stenosis in adults as well as in children, and you will have different indications in different age group. Let's look at the most common cause, and the commonest cause is intubation lesions. So typically what you have is an endotracheal tube pressure, which in turn causes a mucosa capillary perfusion problems, which in turn causes a mucosal ischemia, and within a couple of days, it will give rise to erosions, ulcerations, perichondritis, and this in turn goes into a stenosis process. Typically, you have the endotracheal tube, which actually is going to concentrate its problems in the posterior commissure area. So the entire subglottis, the anterior part of the subglottis, the posterior part of the subglottis, medial part of the arytenoid cartilages, the medial part of the posterior third of the vocal cords on both sides. So this is the area which actually is going to be under this decubitus lesions and going into the posterior glottic stenosis. During COVID times, we have seen that there is a type 5 or there is an extended form of stenosis, meaning that the injury is so intense that sometimes, in fact, you do have a absent posterior cricoid plate. That can happen in a lot of patients, but until now, I think we have been missing out on this. And of course, we see a lot of this in COVID patients. So we have seen this during COVID times, probably secondary to steroid therapy, a long period of intubation in premature kids. So I think this is an extended form of a gradual intense trauma. So this is what we actually see. The acute changes in post-intubation injury are basically of three varieties. You do have edema, so as can be seen here. So typically this patient will present to you with dyspnea and with maybe some steroids, some topical treatment, eventually this edema may settle down and patient does not have any sequelae. The second presentation are granulation tissue. So you will have sort of, severe granulations in an acute sort of, form. And these patients actually present to you with dyspnea, and this probably may have a very high chance of getting into an interarytenoid adhesion formation. And then you have the third variety or ulcerations, where the posterior cricoid plate may be completely denuded of mucosa. Typically, these patients present to you with no symptoms, but these have high risk of causing stenosis, and this can go into both cricoarytenoid joints and going into a full-blown posterior glottic stenosis kind of a picture. Let's look at certain examples. Now remember, these two patients are totally different. Why? Because we treated this immediately. So you can see these arytenoid granulomas, But if these were not treated, then they actually sort of join each other, and then an interarytenoid adhesion is formed. Remember, the posterior mucosa is intact. So going by the Bogdassarian classification, type 1 posterior glottic stenosis. You do have a situation like this, which in turn can go into a cicatricial form of the posterior glottis. So when you're moving the left arytenoid, the entire right arytenoid follows it. So this is a posterior glottic stenosis type 2. And then you have a little sort of, extended form where you have a cricoretinoid ankylosis bilaterally that is secondary to a lesion like this, and you end up having a frozen larynx, a very, very difficult and complex situation to manage. How do we diagnose a posterior glottic stenosis? Of course, the history, the endoscopy, I like to sort of, go with different angled endoscopes. So of course, we start with a flexible endoscopy. You want to look at extralaryngeal airway, synchronous airway lesions. We suspend the larynx. We try to sort of evaluate with different angled endoscopes. We like to sort of, separate out neurogenic causes from mechanical causes, from mixed causes. Difficult to say mixed causes, but you need to go a little bit into the history of the patient as well. So you need to sort of look at the passive movement of the retinoid cartilage. We do our own esogastroscopy. So all the digestive endoscopies, my unit will be doing ourselves because it gives us a lot of advantage of understanding the basic problem. Gastroesophageal reflux, we are able to diagnose by indirect ways or direct ways, and then sometimes scans and biomarkers in autoimmune conditions. Let's look at these two problems. The basic problem is that the posterior glottis doesn't move. So we know that the posterior glottis is the respiratory glottis, and the anterior glottis is the vocal glottis. So you have two conditions. You have a bilateral vocal cord palsy or a posterior glottic stenosis. So here, in fact, you can see some sort of flutter movement of the vocal cords, and these are basically the Bernoulli phenomenon. You don't see an active abduction of the vocal cords. Remember, there's only one muscle or intrinsic muscle of the larynx which causes the abduction or opening of the larynx, and which is the posterior cricoretinoid muscle. So this is a bilateral vocal cord palsy. Here, in fact, you can see some abductory movement of the arytenoid cartilages, but the posterior glottis itself is blocked. So the only way in which you can actually identify that is by just putting in a small vocal fold retractor. If the posterior commissure or the posterior glottis is scarred, diagnosis is pretty clear. Passive palpation of the arytenoid cartilages will definitely give us some more information. Let's come down to the treatment itself. And for me, there are two basic things. They are related either to the patients or certain technical issues that are related that we'll see a little bit later. Let's look at patient-related problems. So these two problems in children and adults are two different issues altogether. We do know the quality of cartilages in children and adults, and this is going to dictate the treatment options or the treatment strategies in these two age groups. We need to consider what is the etiology. Just to give you an idea, give you an example, that intubation-related posterior glottic stenosis or any kind of cicatricial stenosis will be treated differently as against patients who get the stenosis secondary to an autoimmune cause or secondary to a radiotherapy-induced stenosis. Previous treatments, grade of stenosis, vertical extension is very critical. So if the posterior glottis, along with subglottis, along with the upper trachea, etc., all have been involved, then the treatment needs to be sort of personalized for that particular patient. And remember, comorbidities, synchronous airway lesions need to be really, really identified. And remember, comorbidities in children are different, comorbidities in adults are different. And they have some comorbidities which are common between the two. So if you are doing both the age groups, you need to understand the difference between the two age groups as well. And then, of course, your technical issues are related to surgeon training. If you are trained in doing only a certain surgery, you will be doing and opting only for that kind of a treatment. So you need to be, if you're looking at personalizing the treatment, then you need to be also personalizing yourself, meaning that if you have to take a decision, then you have to take a decision what is good for the patient from the strategy point of view. And then, of course, laryngeal exposure during the diagnostic endoscopy. If you don't have a good exposure, then any kind of endoscopic work is going to be affected. There was a very nice article which is related to not just posterior aortic stenosis, but I think overall benign laryngotracheal stenosis itself. And what it says is that minimizing repeat surgeries may improve outcomes. Now, this is quite logical. But what is important to know is that aggressive intervention should be used much earlier than as a last measure. Now, why is that? Now, one can argue in both ways. That why do you want to expose something, in a very aggressive way? Yes, if it can be managed to the bestest of the results by the minimalistic kind of an approach, that's ideal. But sometimes it does happen that, we say that, you could try that, but probably you may not get the right results. So if that is the case, then it is really better to start off with something which is going to give us the best results rather than sort of, keep it as your last resort. So I think this is something which can be discussed, but what is important, what I'm trying to say is that you need to take the right decision for the patient at the right time. And what is required for the patient is really required. So typically for me, the treatment for posterior aortic stenosis is either endoscopic or surgery. I would do it for the sort of, 1 to up to 3 grades or types of stenosis. And something which is a little bit more dense, 3 and 4, will require open surgery. My personal preference for the types 3, so this extended form of posterior aortic stenosis, is following. Primary laryngoplasty with subglottic distraction. And if necessary, then a backup transoral laryngeal microsurgery using the laser for widening. So I first opt for an open surgery and then go in for a backup procedure. And the advantages are that I think it's really critical to have maximum posterior commissure mucosa, and it needs to be as much native or physiological as possible. What it means is that if you opt for going in for a laser procedure or a ablation procedure, whether it is by laser, whether it is by cold instruments, whether it is by coablation, etc., if you are going to cicatrize a posterior commissure and let go the native physiological mucosa, it's not very good. It can be used as a backup surgery. And remember that you have a better judgment of an adequate widening if you already have done a posterior distraction procedure. This is my personal series up till now. So this includes 68 pediatric and a couple of adult patients. They had preoperative tracheostomy, some did not have. The primary surgery was laryngotracheal reconstruction. Endoscopic posterior choroidotomy and arytenoidectomy was done in some patients. For me, I think the most important thing is what I have sort of circled here. 2 adult patients had to undergo a total laryngectomy. So again, we're coming down to these 2 age groups. Remember that in adults, you need to be really, really careful using laser upfront. But at the same time, you need to be careful not to overexpand, that you will end up having, in fact, a aspirating larynx. Of course, in pediatric patients, if you're able to do a good surgery, a large number of them will be decannulated. Endoscopic treatment for posterior aortic stenosis, again, are of multiple varieties. You could have by laser, you could have posterior cricoid splits, you could have mucosal advancement flaps, and then, of course, you have laryngeal ablation procedures. Remember, what are the aims of the surgery? You want an age-appropriate airway. You need to select, or we need to select the least traumatic, and you want to sort of preserve as much laryngeal mucosalization. For me, any surgery will create a large hole. The whole idea is what happens next. So keep your eyes and think about voice and aspiration. So remember, any surgery can give you a large hole, but you need to see what is going to happen afterwards. So again, this is a very simple procedure. You have this interarytenoid cicatricial band. It can be resected, but it needs to be resected from vocal process to vocal process. If you just divide this again, it is going to grow back. This sort of bridge is going to grow back again. So you need to really resect it from vocal process to vocal process. The endoscopic Inglis procedure, that means, you take the laser, you actually expose the posterior commissure, you divide the cicatricial band, you go ahead and sort of, incise the posterior cricoid itself. I like to sort of, put in this graft coming from the rib cartilage. I always have a sort of a small extension of the perichondrium. I like to suture the perichondrium sort of prolongation with the posterior glottic mucosa, with the end result being that you are ending up the surgery with a completely or near complete mucosalization or internal lining of the larynx. I like to use a small prosthesis for a certain period of time just to allow healing in an abductory phase of the vocal cords. A quick surgical sort of, clip that we go with the laser, we sort of use the laser which is axial onto the cicatricial band of tissue. We start dividing layer by layer. Then we sort of, go ahead and do a split of the posterior cricoid plate itself. This is posteriorly, we can see, in fact, the posterior cricoid mucosa. And finally, in fact, we have the posterior cricoid split. We try to sort of expand it, distract it by using a small balloon, which is age appropriate. We put in a rib cartilage graft, and then we suture the native mucosa with the perichondrium. And then finally, we put in a endoscopic insertion of a prosthesis, and the idea being that it allows the healing process with the two vocal cords in an abductory phase. What about mucosal flap? So one can also think in terms of actually incising this with the laser, and then actually creating a vertical incision is sort of taking release incisions laterally that allows you to get an anteriorly based or a posteriorly based but anteriorly transposed mucosal flap. The whole idea is to sort of have the larynx completely epithelialized at the end of the surgery. Your discussions with your anesthesia colleague is going to be very tricky, and what kind of technique you use in these very small children is also going to be an issue that you need to discuss with your patients, with your anesthesiologist. After the surgery, we always try to give forced abduction exercises. Again, the same story. You want the healing process in an abductory phase of the vocal cords. Temporary lateropexy. Again, the idea being to put in sort of, a lateral, sort of laterally based proline stitch or a non-resorbable stitch. Sometimes I use, in fact, a neonatal feeding tube and pass the proline stitch through that to avoid cheese wiring or a concentration of stress forces of the proline on the cartilage, which can cause sort of breakthrough of this stitch. Now, remember, open surgery itself is either a laryngotracheal reconstruction, that means distraction of the posterior commissure and the posterior cricoid, or if it is a multi-stage sort of stenosis, meaning posterior glottic with subglottic stenosis, then an extended cricotracheal resection. What is important is, if you need an interarytenoid expansion, it means that you need to have a posterior cricoid split with an expansion graft. So this is just to sort of show you that, the way we take our rib cartilage, it always has got some sort of, perichondrial sort of flanges on both, on cranial and the caudal sides. And then you have these small flanges laterally of the cartilage that allows suturing. We always like to suture the cartilage. It is much more stable for us. Just to sort of tell you that children will be different from adults. And in children, the surgical preferences are the same. They will be same in children and young adults. However, in older patients, probably ablation might be an interesting option because the cartilage quality is not very good. In the interest of time, I probably am going to I'm going to skip the surgery itself of an anterior posterior rib. I don't know whether I have too much of time, but in the interest of time, I'm going to skip this and go to the next slide. So this is, in fact, a 3-year role. Preoperatively, we had a posterior glottic stenosis, grade 3 subglottic stenosis. I think what is important to note is the native mucosa. So more is the native mucosa, I would prefer going in for a laryngotracheal reconstruction. So this is, in fact, after an anterior graft, posterior graft, and following a decannulation. What I'm trying to say is that until now, we have always considered the grade of stenosis. The native mucosa in the larynx and the trachea, I think, is really important. We do a lot of esophageal surgeries for esophageal replacement for caustic injuries and caustic pharyngo, esophageal stenosis, etc. It's the same principle. It's the native esophageal mucosa. So similarly, native laryngotracheal mucosa is very, very critical. Let's look at the adult side. This is a 52-year-old sent from Slovenia, prolonged intubation, COVID ARDS, and then in fact, she had a multi-level sort of stenosis, and she had undergone an extended cricottracheal resection, and this is the end result prior to her decannulation. What is important to know is that all surgeries do have complications. The question is, are you able to manage these complications? And this is really the trick part. The surgery is simple or it could be difficult. But the complications are complications and they will come with a certain price. So the whole idea is to avoid complications and if possible, treat them whenever it is needed as quickly as possible. When we do a laryngotracheal reconstruction itself, remember that you could go off center line. So, either you could go through the ligament, vocal ligament, or you could go through the posterior cricoid and go into the articulation itself. So remember that this needs to be avoided. You could end up having an overexpansion, which in turn can cause problems with voice and aspiration. This can again be treated. It's not that you cannot treat it. It can happen and it can be treated. Graft necrosis will cause recurrence of posterior glottic stenosis. Sometimes, the cartilage itself can exteriorize. So it can either drop in front into the airway or it can go behind into the esophagus. And this will require a salvage surgery. Selena is a 3-year-old. She had a button battery ingestion at 19 months, and then she was tracheostomized. So these are typical things. So you have a caustic lesion in the upper esophagus or in the cricopharynx. You have an intubation done. So in fact, the posterior commissure is squeezed between two insults, a foreign body endotracheal tube and a caustic lesion posteriorly. And this can be a very, very tricky situation. Why? Because Selena had, in fact, a cartilage which was inserted for a posterior cricoid expansion dropping into the esophagus. So in fact, you can see that there is a hole or a pharyngolaryngeal fistulization. And this is the whole cartilage actually dropped down into the esophagus. What did we do? We mobilized from the esophagus the mucosa endoscopically, and we used some clips. The whole idea being that, you want to recover, you want to reposit the cartilage back. It was not that the cartilage had fallen down into the esophagus. It was exposed and it was getting sort of, into that area. So we only sort of, mobilized the mucosa from the esophagus, put a couple of clips, and this is per 6 months at decannulation. So yes, it can happen, but you need to sort of, understand the problem and try to take the proper steps at the right time. Very commonly seen currently in COVID patients. So just to conclude, prevention of posterior glottic stenosis typically requires a timely endoscopy and timely endoscopic treatment of intubation lesions. Endoscopic treatment could be a variety. You could use the laser, etc. The aim should be you want maximum mucosalization. You could have endoscopic procedures or you could have open procedures, but remember that something to distract or something to separate out the two arytenoid cartilages is what you're looking for. Surgical details are really, really important. Thank you so very much for this invitation. And I wish you guys a very nice congress, very nice conference. And it was lovely seeing you, Andile, and it was lovely seeing you, Shan. I look forward to seeing you sometime in person in the future. And I'm happy to take any questions.
Thank you very much.
Any questions?
Sorry, I didn't hear, there was a question, I didn't hear that.
No, sorry, we're just trying to get the mic to work. Here's a question, yes, fine.
How do you shape the cartilage for an endoscopic cricoid split versus an open RCR? Is it the same design?
Did you get the question?
Yeah. So it is the same design, except that, if you have to go in with an open surgery, you want a little bit of perichondrium distally as well to suture with the tracheal mucosa. You probably have a little bit longer sort of perichondrial extension cranially, because that allows you to put the sutures between the perichondrial extension and the posterior glottic mucosa. And I like to put these sutures from outside so that, because later on it gets a little bit sort of, difficult to sort of guide those sutures. So again, technical details, but yes, they are slightly different, but eventually you want to end up, having a mucosal lining at the end of the surgery.
Can I ask, you talk about timely treatment of injuries, intubation injuries. What does that mean? Does it mean going to theatre and injecting the steroids early on when you see early injuries? I would think removing stuff might cause more injury.
Yeah, I mean, if we have intubation lesions, the idea would be to really go down to the theatre. We always go down to the theatre. And the whole idea is to, identify the lesion, identify what could be sort of treated. You'll be very surprised. Sometimes you could have granulation tissue, you could have this fibrin, which has been sort of, plastered because of the endotracheal tube in place. So it's only when you sort of, remove the endotracheal tube, because that has stented the larynx and the trachea, only then you're able to visualize the problems. It's like, if you have a stent, a suprastromal stent in place, till the stent is there, you don't see the granulations. But when the stent is out, you sort of, start sort of plucking out the granulations, and that's where you start seeing what should be done additionally to prevent a certain problem. So yeah, I mean, if need be, if we go to the operating blocks, we have a dedicated endoscopy suite, so which is doing only endoscopy work, and that allows us a lot of leverage. It allows us a lot of possibilities of looking at the problem correctly and then treating it in the right way.
Thank you. Any other questions? No. Thank you very much, Professor.
Thank you so very much. Really appreciate and have a wonderful congress. Very wonderful congress. Bye-bye.
Our next speaker is Dr. Larissa Grenier, who's our head of department of anesthetics here at Albert Atuli Hospital. And she has a vested interest in pediatric anesthetics. Yeah, thank you for giving us your time.
Right. Thank you very much for the invitation. Oh gosh, a bit echoey. It's always a pleasure to be with ENT people in the same room, because I think we're the one set of people that really know, insult Mr. Goodler, who really understand each other's issues. And I think ENTs are one of the few people that really understand what we may go through, but also you're one of the few people that we can call when we're in trouble. So I think it's a mutually beneficial relationship if we understand each other. And so maybe today's talk about the shared airway is to kind of share some of those understandings and kind of what we're understanding when we're trying to oxygenate and get the airway going fully well, understanding what it is that you need to be getting on with. So the definition of a shared airway refers to the anesthesiologist maintaining the airway and ventilation and hopefully sort of vaguely some form of anesthesia of the patient as the surgeon performs procedures in the same anatomic space. Now, has anyone here travelled to Vietnam? Okay, put it on your bucket list. But you honestly see these pictures, an entire family precariously perched on a bike, and sometimes it's a couple of pigs on the back and some furniture and whatever else. So it feels to me like this is us all crowding onto this tiny little precarious set of wheels. But they seem to just do it with a smile on their face, look at the joy and enjoyment of the little girl in the front. And so I think we can share this space joyfully, as long as we all know what to do not to tip over this bike. And another picture from Vietnam. So what is the aim? Our aim really is to maintain anesthesia and oxygenation and some form of ventilation, and I use these words quite specifically, to keep the field still for you and hopefully not inadvertently gas out the surgeon. And sometimes this balance is just quite hard to find. And just like this very precarious situation here, one of those wheels gives in and the whole thing comes toppling down. And we know how quickly an airway can change from one of cooperation and being in control to one where we all just feel like the wheels are falling apart. And so I think that pre-planning and communication is something that I'm not even going to say repeatedly, because I'm taking it that we're in a room of people who fully understand that that is the only way we prevent any kinds of airway catastrophe, is that constant communication and collaboration. So just to let you know all of the different kinds of approaches, and there are a couple of really good articles that divide up the approaches that we can use in a shared, and I'm not talking about all forms of ENT surgery, mostly when we kind of in the same area around the larynx, the one that we quite like, and the first part of the trachea and the lungs that we're all quite fond of, but you need to be getting on and doing things over there. So the different techniques that we can use is tubeless, which is usually some form of spontaneous ventilation, and the old-fashioned kind of positive pressure ventilation with an endotracheal tube, and a lot more people are now describing surgery with a supraglottic airway, and it's probably a direction that we need to start thinking about moving towards. We don't use it very often. I don't know if you use it a lot in Australia, but I think we're still quite attached to either tubeless or ETT, and maybe we can find a middle road. Cross-field ventilation, which I'll explain, jet ventilation, the fancy jobs, ECMO and cardiopulmonary bypass, and then what's there on everyone's mind is apneic oxygenation, and we'll talk a little bit through that. So the truth is, tubeless spontaneous ventilation is so 1846. It was honestly the first form of anesthesia, and the first surgery done was a surgeon, Mr. Warren, and it was William Morton who was the anaesthetist, and he was sort of vaguely gassing something at this patient, some ether, and as you can see, this was an ENT surgery. So the truth is, tubeless spontaneous techniques have been there. That's all we had in the beginning. And then I think we kind of thought we would get fancy because a lot of things went wrong. So what could go wrong with this technique? Well, it was the original method of anesthesia. Obviously, the forms of ether and the types of anesthetics that we had meant it was just like you were taking your life and the patient's life into your hands. Aspiration, airway fires, and depth of anesthesia was utterly variable, completely unpredictable, and mostly a deadly continuum. And I think then as safety came in, the move was far more towards a tube plus minus paralysis, and we thought that's a much safer way of doing things. And if the surgeon needed to see the airway, we'd get the tube in and then take it out, do your business, and then get back in and put that tube in, because that's the safest way of doing things. So I think from the first form of anesthesia, then a very unsafe form of anesthesia, we kind of moved in a safe direction. And really, it's been a full circle. And I think the game changer to this full circle was propofol. I think without propofol, we might still be absolutely struggling, because there's nothing else that gives you reasonable spontaneous ventilation, that kind of manages the airway quite effectively, provides a good depth of anesthesia, quick to wake up, in and out. So literally there's just no fault to find with propofol, except the child we did last year in our workshop that got propofol infusion syndrome. But I mean, that's in the ICU, and that's when you're hosing in liters, or you have a very susceptible patient. So I think this was the game changer. And when I started, it was intermittent boluses. We just gave a bit along the way. So when we used to do papillomas, it was a big pile of Remicade, and you kind of globbed the tube into the Remicade, went in, and then you had gas, and then it came out, and everyone coughed and spluttered, and you did your thing, and then you went back in again. And when propofol came, it was just fantastic. You gas the kitty down, get that tube in, and then you just gave little boluses of propofol moving along. And kind of we just worked out how to do it. The next thing that came in was TiVo regime. So this is a mils per hour. We are not just doing it intermittently, but I'm setting a mils per hour. And you can see there are two regimes that we use, the 10-8-6, so that's 10 milligrams per kg per hour for 10 minutes, and then coming down. That was the adult regime, and obviously children, because of higher volume of distribution and metabolic rate, we'd use 15, 14, 12, 14, 12, 10, 6. These were quite sort of variable, and as long as the child wasn't coughing or, on the other hand, apnea, we were quite happy with this. TCI has been a next game changer, but certainly it's just been an advance on the use of propofol. I don't think it's fundamentally changed things for me, but people that use TCI all the time will absolutely say it has been as big an impact as propofol. And that means that we are setting an effect site concentration. So rather than calculating mils per hour, we're saying we want the concentration in the brain to be X. And there have been multiple models developed, some on patients taking blood concentrations, but a lot of inferences for age, inferences for gender, inference for children. So very few of these models are actually suitable for children under the age of 12 until we get to another game changer that I'll talk about later. And I think in the future, we'll probably be doing AI. There'll be some kind of feedback loop mechanism. AI maybe makes it better. So like yesterday, we had TCI running, we were really happy, we had our BIS and the patient coughed. So, you know, we think we're getting it right, but we just don't know what all those little nuances are. And then I think the recipes really are your preference, your experience, and your resources. And you can literally do anything from just propofol in your hand to setting fancy TCI models, remifentanil, L-fentanyl, dexmedetomidine, ketamine. I really think as long as you're developing a recipe and actually learning how to modify that recipe rather than doing different things all of the time, and just knowing what I'm adding in. Is it a very painful procedure? The menu is very useful. Is it one where I want post-operative sedation and kind of a nice wake up? Then your dexmedetomidine is a lovely agent to be using. So the thing with tubeless spontaneous ventilation, I think it's not just what you do, but how you do it. And this is where it becomes very much an art and not a science. We can put all of the science in, and there are just some people that have kids breathing quite happily, the surgeon's going on, they wake up quickly and they're recovery, and others where they're just coughing and spluttering, and then they're apneic, and then we're putting the little goodie down to try and oxygenate them, and the whole situation just doesn't feel full. And I think we have to do things often. I think things that you can help is topicalizing the airway. We should ultimately use 4% lignocaine, but the one easily available is 2%, the other one is 10% in the cardiac theatre, and they won't part with it because it's so dangerous, and then you have to mix it up and you can get it. But ideally, to topicalize the airway, you need a 4%. You can atomize it because then it's not just sitting on the larynx, but it's further down, and a lot of your stimulation isn't just on the trachea, but it's getting down into the trachea. It can be very stimulating. And so you might be fine on the upper airway, fine on the larynx, and then suddenly when you're hitting the trachea, then things are falling apart and the child larynx spasms, desaturates, and you kind of have to then make them deeper, and you're getting into a cycle. And these kind of things, topicalization can be modified in various ways. Oxygenation, we're going to have quite a few slides on oxygenation, but there are various ways to supplement oxygenation. And I think it's resources, familiarity, and what your purpose is. And it can be both continuous and intermittent, and I'll spend some time going through those. One of the biggest problems with tubeless technique is depth of anesthesia is always a continuum, and you're never exactly sure where you are. And you can use the child's respiratory rate and absence of coughing to the surgeon as a method, but the truth is we're probably a little bit deeper than we want to be, and that's inherently what we would rather do. So that means I might be breathing spontaneously, but my minute volume is depressed. And irrespective of the fact that that child is breathing or adult is breathing spontaneously, they will have CO2 accumulation. Now, temporary respiratory acidosis, most of us can cope with it absolutely fine. It really is a novel. Towards the end, they start breathing it off and they're fine in recovery. But there might be conflicting interest. You want a longer period where we're not intermittently ventilating. You want a greater depth of anesthesia so the patient isn't twitching every time you're doing what you're wanting to do. And so I think there has to be a discussion beforehand. What are the periods of time that you need to be out there or in there, and to identify high-risk patients. And for those patients, we have to set limits. So I would say any child with chronic lung disease, pulmonary hypertension, probably neurological issues, they're not going to tolerate a higher CO2. And certainly pulmonary hypertension for me would be a very big red flag. patient for monitoring, even if they're breathing spontaneously, because I just don't know what that CO2 is doing. And there have been quite good studies that have a look at transcutaneous CO2 monitoring, and it's certainly not a dramatic rise as long as your child is breathing. But in the wrong type of child, that could just precipitate upon the hypertensive crisis or bradycardia or further problems. And it, of course, just means that we are constantly backwards and forwardsing. Somebody needs to be admitted to the room. Can I admit them?
My apologies, I'll do
Yes, no, that's fine. There you go. Okay, so that's with tubers, and we'll get a bit more to how to oxygenate during tubers. Next thing is positive pressure ventilation. Well, it's pretty old-fashioned. I mean, the old red rubber tube, positive pressure ventilation, it comes with guarantees, and we like the guarantee. It's a secured, protected airway. So high-risk aspiration patient with absolutely cruddy lungs. This is the kind of thing that you want him to do. You can ventilate, you can monitor your CO2, you can monitor your minute ventilation, and so I've given the kind of risk patients that there. You can use inhalational anesthesia because not all of us have the resources for propofol or TCI, and so a low resource setting, this might be a more appropriate method to go. And you really can knock yourself out with multiple routes: oral, nasal, tracheal, submental for maxillofacial surgery that we sometimes do down in the trauma unit, and a variety of different tubes. So you really have the world is your oyster in terms of endotracheal tubes and working around them. And microlaryngeal might mean that you know, but the biggest problem is, if there's something sitting there and I'm shoving a good old tube down it, and invariably it's difficult airway, so I've got an introducer, I may be sending infected or other material down into the lower airway. Your surgical site is, of course, far more limited. So certainly, as I said, in the old days of the papilloma, the tube was in, you bit around, in and out, then we might be putting a bigger and bigger tube as obviously you sort of debulk in papilloma. So I think it was kind of a far more, you actually needed more communication in those days than you do now, as long as you've got a good technique going. And the other thing I've said is this is non-dynamic. So the one nice thing about a spontaneously breathing patient, you've always got an idea, especially if you're doing an EUA of the upper airway, of what it looks like. How does it perform? What do the cords look like? Is there indrawing? Is there laryngomalacia? By the time you've got a tube in and you're paralyzed, there's very little dynamic assessment that you can do of that airway. Crossfield, so there's two forms of crossfield. I've sort of described this old-fashioned way of doing papilloma, which just means that we get in, we go through the field, which is your papilloma bed. I'm just using that as an example. I oxygenate, I put the child back to sleep, we pull it out, you nibble, and we go back in again. So that's cross-field ventilation. But then obviously also for the more complex surgeries, like tracheal reconstructions and all these kinds of things, we also are doing some form of cross-field. In other words, our ventilation is right in the middle of your surgical field in some form or another. And obviously, if it's in complex surgeries and we're across a complex field, there needs to be good periods of combination, communication about who's doing what when. And what tubes fit and don't. The advantages, once again, across field, it's not dynamic. There's a lot of to and fro and interrupted surgery. It's kind of inning and outing, and you can't just get in there with your business and get out and do it. And if you are doing it with inhalational anesthesia in a low resource setting, you will get contamination in the theatre. And people have some ways of sort of putting some form of distraction techniques away to get rid of the gases. So jet ventilation, going the way of the Boeing company. We all know Boeing is having some serious issues with its stock at the moment. And it's just their safety record, things are going wrong. And I must admit, one of the things that I'm the most terrified of is a jet ventilator. And I think it has huge advantages in rescue airways. And you can always get the oxygen in. That's not the problem. The problem is getting the oxygen out, especially in a restricted airway. So if you've got a more open airway, you can use jet ventilations of various forms. But that restricted airway, you have to know what has gone in. How is it coming out? Otherwise, over time, you will just get tension pneumothorax work, surgical emphysema. And I mean, there are just hundreds of case reports in the literature about disasters from badly managed jet ventilation, traumatic airways, and you've created false tracts and massive surgical emphysema, tension pneumothoraces, etc. So you really have to be extremely careful about what you're doing and understand the pressures. And if one is put in your hand and it doesn't have some kind of pressure regulating valve, reject it. It is not safe to use. And certainly, so that's the sort of safety features of the pressure regulation. And also there's a newer version here where you can actually set the setting. So rather than, sort of doing this manual thing, it's a form of a ventilatory mode that is now set on a ventilator. And so you can set all of the limits and frequency, and you can have high or low frequency jet ventilation, etc. But it certainly has a place in certain critical airways, but not that we use very often. And of course, the other thing is entrainment of contaminated material into the lower airways is a major problem with jet ventilation. So complex cases, this is not for the faint or inexperienced. Exit to ECMO procedures, exit to bypass procedures, and these are when we have complex upper airway lesions. We recently did an exit procedure, and the child went straight into ICU. In fact, I think I'm still there, he's on an oscillator, so we're not. But he went via the oscillator. So these are for complex surgeries, and this has to be a highly experienced team. I think part of the problem with what's happening at Albert Lutuli is we're doing three exits a year. So we're not developing that pathway to managing these children properly. So we get bits of the pathway correct, but the chain links to make sure that it is smooth beginning to end doesn't happen. So each of us has areas of expertise, but it's all of that coordination that is not working for us at the moment. So I think that's a challenge for us for the future. The other patients are patients who just in ICU, they're not handling well. We're trying to bring them to theatre to do some kind of upper airway. Everyone's inning and outing of the in ICU. Can we bring the baby? Can't we? Oh gosh, they've now gone into a oscillating ventilator. What are we going to do? Can we do this or not? So it becomes very difficult. And I think I remember last year, Prachan was talking about the modified theatres that you've got attached to your NICU. And I think that, so they are hybrid theatres attached there. That team is highly experienced in actually managing these critical neonates. So I think both of these areas are gaps that we have. We have the individual skills, but we're somehow not linking it to do these more complex forms of offerings to our patients. So we've had patients on ECMO, but it's been very haphazard. We can't get the consumables for it. Who's done the training? Who hasn't? We've done the exit. Why can't we get the MRI in time to be able to get them into theatre? So this is really our limitation for the more complex management. So the next thing, so I've talked about all of these different ways that we want to manage that airway and secure that airway. And some of them are spontaneous modes, some of them are not spontaneous modes. There are situations where you just need a patient to be apneic, and that is the ideal situation for you. And this poses a big challenge for us, because as I've said, there is a little climb of CO2 during spontaneous tubeless, especially if we're getting our depth of anesthesia a little bit wrong, but it's the kind that we can manage. But it's when we now need a completely apneic patient, and we're trying to think of a way of oxygenating them, and maybe in the best world, a way of eliminating CO2, so in other words, of ventilating them. So being completely apneic, the longest breath hold, Guinness Book of Records, is Wouldemir Sobat, if I'm saying it correctly, 24 minutes and 57 seconds he held his breath for. I mean, that is just mind-blowing. Don't try it in your pool this afternoon when you go home. It's a major way of learning how to do it. So they do breathe 100% oxygen beforehand, but it is a long period of training of actually switching your brain off. So the early reason that we want to breathe is because maybe our sacs are falling and then CO2 kicks in. So it's either our hypoxia that's making us breathe, or it's our ventilatory drive. And these guys just learn to switch it all off. But of course, with all of the issues of shallow water blackout, and if you're doing the Wim Hof method of breathing and whatever, there are multiple. I don't know if any of you follow Wim Hof. He's the Iceman breath holder, whatever. But I mean, don't follow people on social media and try and do this, because there's only deaths associated with it if you don't really know what you're doing. So we don't want to be doing complete apnea, because we just haven't trained for this. So we want apneic oxygenation, and it's wonderful, but remember, it is not ventilation. So the advantages are it certainly prolongs your apnea time to desaturation. So highly effective in difficult intubations and things like that, where you're trying, instead of that kiddie, bragging and desaturating within 2.5 minutes, you've maybe got 5 or 6 minutes that you're going with. So I think extremely useful in prolonging time to intubation, especially in inexperienced users. There are multiple different methods that we can do apneic oxygenation, and we'll talk through them. And the nice thing about an apneic patient is you not have a stall surgical field. So you're not pitching in and out of laryngospasm or different depths of anesthesia or a cough or a swallow or any of those kinds of things. So obviously it gives you ideal conditions. The problem is, in terms of ventilation, in terms of the only place where gas exchange is going to take place is in the non-dead space areas. So dead space is all of the bits of equipment that you've got. It's the larynx and the first part of the tracheobronchial tree, and even to an extent, some of the alveolar dead space if you have patients with atelectasis, whatever. So no gas exchange is happening there. So it's actually quite easy, even if you don't have have a lot of dead space or don't have good ventilation, to keep patients oxygenated. That's not a huge challenge. It's always the elimination of the CO2 and the limit that becomes the rate limiting step at the end of the day. So obviously the disadvantages of apneic oxygenation: no CO2 elimination, there's no airway protection, and you're going to need to interrupt your surgery, but you certainly have a very still and optimal field, and we can try and extend that time that we've given you for that optimal field. So what are the different methods of oxygenation? Absolutely excellent article 2020 in Anesthesia and Analgesia. I would refer you to this anesthetic journal. I think certainly for the registrars, it would give you such a good account of all of the different methods of oxygenation. So really the humblest and the simplest is the old nasal cannula, and you now get high and low flow, and I'll probably put something like Airvo somewhere between nasal cannula and Thrive. So Airvo obviously is, you can use higher flow, you get some humidification, but you require a patient to be spontaneously breathing. And the interesting thing with nasal cannula is you can get some kind of positive pharyngeal pressure of maybe 4 centimeters of water, depending on the studies that you do. There's modified nasopharyngeal airways, there's a catheter in the pharynx, modified instruments, including what we do here, and Thrive. So I'm going to go through all of these with a quick what is good about them in blue and what we don't like about them in red. Have I got 5 minutes? Okay, thanks. So nasal cannula, it's continuous, it's cheap, it's available anywhere in the world. You can put the nasal cannula on and you can mask ventilate. It doesn't actually stop you mask ventilating. So it's very useful for intubation, but you have to have an open airway. It's going to do nothing without an open airway. And so there are a lot of studies that say it doesn't actually maybe even matter what flow you're using. It's the fact that you have flow and the fact that you have an open airway. So they've had studies with no flow, high flow, no jaw thrust, and really low flow with jaw thrust gets you the same kind of outcome that you need. So very humble and easy to use. The problem is you need an open glottis, and gas that is flowing will find the path of least resistance. And if the glottis is closed and it's flowing, and the higher the rate it's flowing at, and if your tongue is now applied to the back of your throat and it can't flow out the mouth, it is going to flow into the stomach and then into the bowel. So that gas will flow somewhere. And certainly the Nissan, even the Nissan this morning, we had some gas in the stomach and we didn't think that there was any. So you need an open glottis. It doesn't cope with upper airway obstruction. So nasal cannula are not good for upper airway obstruction. Your FR2 is kind of, you don't really know where you're at with it. There's no humidification, there's no CO2 clearance, and it's not that useful for surgery because I can't do much else other than, so I think ideal for intubation, but not really for surgery. The modified nasopharyngeal airway overcomes, so just a nasopharyngeal airway, you can have fancy ones, and you can cut a bygone and put the top of an endotracheal tube in it, put it in the nose, and you basically overcome upper airway obstruction. So it's very useful for that. And you can then attach that onto an anesthesia circuit. So we had that kiddie last week, I think, Mr. Kapoor, where we had a nasopharyngeal airway. It was a very difficult fiber optic intubation on the other side. And I just quite simply held my hand over the mouth, nasopharyngeal airway, and then I could bag quite comfortably without the tube being anywhere near. So we had a child that was actually being ventilated, oxygenated, and we had all of the time in the world to do our fiber optic intubation. So cheap and easy. And as I say, if the mouth is closed, you get CPAP. So what do? You just put a dummy in a kid's mouth, they suck on it, they've got modified nasopharyngeal airway, and they've got good CPAP. So that's how they get the kiddies to close their noses. And then oxygen via various pharyngeal catheters, and obviously don't put the catheter in the stomach, but if you can sort of create some kind of modification and just have the catheter in the back of the pharynx, and that can provide you with some oxygenation. The ventilating bronchoscope, great, you can jet through it, you can do positive pressure ventilation, you can do oxygen delivery when the glottis is closed by putting it through, but it can be intermittent. We've got a lower FiO2, certainly in a spontaneously breathing patient, no humidification, and obviously now I've rescued the airway, it's down there, I may be able to do what I need to look at down in the different bronchi, but if I'm trying to do any kind of surgery, I can't do it with a bronchoscope, it's going to be quite difficult. And then your suspension laryngoscope using various side ports, and those can be quite useful as well as methods of oxygenation. So the last one I'm going to talk about is Thrive, and does it really live up to the hype? So we've got all of these different methods, and all of them in one form or another, you will get oxygenation going, and you can provide a form of anesthesia. But can we get rid of the CO2? And I think this was really the big thing, where Thrive was initially punted as you can get a much higher FiO2 up to 100%. So with Airway, you can't get up to 100%. So you can get a very high percentage, and you can get a kind of almost a sort of semi-vibratory ventilatory mode. It's very accurate, it's continuous, it's humidified, and you get some, and I'm going to use the word some, CO2 clearance in adults. So I'll probably say it's a slower rate of rise than it is necessarily clearance, and CPAP when the mouth is closed. The problem, once again, ineffective with an obstructed glottis. It's costly, it's difficult to set up, and it can interfere with mask ventilation, and it doesn't really deal with other airway obstruction. So just a couple of studies that had a look at comparing all sorts of things with all sorts of things, from nasal, Thrives, high flows, Airvows, and there's only one message that is really important on this slide. It don't make a damn bit of difference in kids. You will not get CO2 elimination, whatever form you are using. You may get better surgical access, you may get better oxygenation, you may get better upper airway opening, you will not get CO2 elimination. So the rate of rise of CO2, which is rapid and then kind of plateaus and just goes on forever, is the same in children. And so you can see the black and the sort of darker is the rate of CO2 rise, and the white is comparing it maybe with high flow or something like that. So even if you're comparing no flow to high flow, low flow to high flow, doesn't make a difference. Whereas in adults, you can see there's a huge difference, almost a 50 to 60% reduction in the rate of rise of CO2. So it's highly effective in adults. And I think this slide just says it again. So all of the studies that have been done in pediatrics, your rate of rise of CO2 in millimeters of mercury per minute will be that. So you can even sit there and work out in theatre. We've been, apneic for this amount of time, our CO2 is likely to be that. And you can see in adults is almost half of that of children. There are actually more studies in children comparing control to Thrive. In adults, it's historical controls of the rate of rise to Thrive. So actually better performance in the pediatric literature. I've got two more slides. Firstly, so what do I think the future is? Well, I think in terms of TCI models, the Alefeld model, which we've got two pumps. So blue means we've really got it at Albert Lachili, and it is down to neonate. So if you have an anaesthetist and they like TCI and they're hesitant in children, tell them to get the Alefeld model, because it is validated for obese patients across the age spectrum and even down to neonates and preemies. So it's one of the few models that's included it. I think you need to go to depth of anesthesia monitoring. Yesterday we had the BIS. The BIS said this patient's asleep, but it didn't tell us much more. It didn't tell us they're about to cough or about to do this. Whereas if you've got the same monitor and you've got the sort of more raw EEG, you can actually get a better idea of where your patient is. So we can give you a more steady situation. Transcutaneous CO2 monitoring, so the black is what I would really love. I think they're great. They used to only be available in adults, now they're getting in children. It's like a little, almost like a little pin similar to the insulin monitor now that you can put it in their various sites. And I think that's certainly in ICUs and so on, they're using that. So I think that could be very valuable. And I've actually put a question mark next to Thrive, given that the majority of our kiddies are airway surgeries that we're doing, where we're doing tubeless with children. I'm not sure for the cost and the issue that we are actually going to gain anything. And then I think for everyone, it's about AI models in the future. So thanks very much. Any questions? I mean, I think just to summarize, adapt the technique to your unit. I think that's probably the most important thing.
Any questions?
Why does Thrive not work in children? Why is?
Oh, sorry, I didn't actually have the slide there. So the theories are that children have more.
Sorry, for those online, you can
Okay.
just speak into the.
So the question was, why does Thrive not work in children? So I think that there's sort of various theories around and about. And I did briefly have it up there. The first is that they have more dead space to smaller FRC, quicker closing capacity. So I think you're just dealing with a less friendly anatomical environment and gas exchange environment. They have 2 to 3 times the metabolic rate. So so it may even be that they're just generating stuff, using stuff, oxygen much faster and generating CO2 much faster. So I think that very low kind of CO2 elimination or rate of rise that is happening with the Thrive is just not big enough to catch up to their metabolism. And the third thing is, once again, just because of the anatomical airways, the way that the gas exchange is supposed to happen is actually by turbulence in the airway, because remember, there's no positive ventilation moving in and out. So the theory of it is that it's turbulence. But because the children's airways narrow so quickly, you think there's more turbulence, but it actually goes down to a laminar flow in the gas exchange areas. And so you're unlikely to be able to get that gas exchange. So that's the theory at the moment about why it doesn't work.
We did a randomized control trial looking at Thrive.
Sorry, can I give you the mic?
Yeah. There's an Australia-wide, about 6 institutions published a couple of years ago, and we didn't find any difference in the 2 groups. But I do think in paediatrics, if you have a long endoscopic case, Thrive may make a difference. So if you're doing a laryngeal cleft repair, something like that, we put even our short diagnostic scopes mixed in with the long cases. And so actually, where we're looking at stratifying our patient population into 2 groups now, or maybe even 3 or 4 groups, depending on the duration of the procedure. And I think we may find that Thrive has a benefit in the longer cases, but maybe not in the shorter cases.
I think that's a good point. So it's about patient selection and, so I think just having in your unit, if you're not doing those longer cases, it's not going to be cost effective in any kind of way. Do you think it's the humidification that is the assistance, better oxygenation overall, or maybe we just haven't taken that CO2 elimination kind of far enough, or?
I think there's long cases where you've got prolonged tubeless anesthesia in a spontaneously breathing patient. Often at the end of the case, they start developing some atelectasis, and that messes with your gas exchange, or you get a VQ mismatch, and so shunting, etc. So I think if you somehow can reduce atelectasis by giving some form of high flow or positive pressure, it may mean that you get less of that at the end of your long case, like the 60-minute endoscopic procedure without a tube.
Thanks very much for that. It's interesting.
I'd like to introduce our next presenter. There's Dr. Sizakile Mukati. She's a locally trained graduate and has been up to Pretoria to do her training as a pediatrician, and has now returned here to do a fellowship in pulmonology. And this one of our members from our multidisciplinary team, we're grateful to hear you talk. Thank you.
Good afternoon, everyone. I'm Dr. Mukati from pulmonology, and I'll be representing my Peds ICU and the pediatric team. So we're just going to go through the approach to the difficult intubation. The reason why we have friends in ENT, they always called for that reason. And also our anesthesia people as well. Those are the people we call whenever there are struggles. And some of the reasons why we actually get these difficult intubations is because of our patients coming from the base. It's not because the intubation was difficult, maybe sometimes because of the skill, and also those are the things that we actually need to talk about and just relay back into our base hospitals. Okay, so I'm just gonna go through the definition and statistics, and then anatomical features, which is quite important for our patients because of the nature of how our patients are. They're not little adults, they are pediatric patients, so the anatomy is completely different from our adult population. And then the physiological features. So the physiological features are just not gonna, we're not only gonna talk about just the airway, but the whole patient as a whole. Why is it gonna be difficult for us to ventilate these patients? And then you have to be able to identify these difficult airways prior to running into problems when we actually have to rush and call everyone in the middle of the night for a difficult intubation, and just look at our management strategies for those anticipated difficult airways. So the definition is from the American Society of Anesthesia, which defines a difficult airway as difficulty with assisted ventilation, difficulty with tracheal intubation, or both. So you can see here, it's not only just getting the tube in, but how you're going to ventilate the patient that forms part of your difficult airway. Okay, and then some of these difficulties have been shown to be more common in the pediatric population as compared to the adults, and particularly in patients that are less than the age of 1 year. Those are the patients that a lot of people struggle with. They will come with injuries from those difficult intubation. And difficult mask ventilation is estimated to occur in about 6% of children, which is 4 times more than the adult population or the adult statistics for difficult mask ventilation. And then difficult intubation is actually less common and occurring in about 0.5 to 1% of all the pediatric population. But the majority of our difficult airways or our difficult intubations are the younger patients, which are less than the age of 1 year. And when you look at the anatomical features, okay, so like as I had said that the pediatric population, the airway looks completely different. So there are general features that we actually, with all the pediatric population, and then there are those specific ones that are specific to certain conditions. So if you look at the larynx of a child, so most of these patients, it's anatomically, it's usually higher and more anterior as compared to a bigger child. So that's why even when I intubate a bigger child, it always looks like, why is it so visible? But if in a small baby, you know that you have to do special maneuvers. And also when you look at the laryngoscopes we use, they're actually different from the ones that you use in adults because it just looks too easy. And then when you look at a smaller child, you actually have to lift up the tongue because it's can be quite big. And also the other issue is the head. The head always looks bigger. Their occiput is a bit more prominent. So when you're putting in a baby in a neutral position, the head, it always looks like it's a bit flexed. So you're not gonna get just the tube and just the alignment of your airway to actually see it properly. So it's gonna be a bit difficult. So you have to do different maneuvers. For the smaller babies, you actually have to tilt them a bit and put in at least something up behind the shoulders just to straighten your view of your glottic view. And then there are the special ones, like your congenital or acquired conditions, like in your Down syndrome with those patients with microglossia, which can obstruct the airway. And also in terms of ventilation, you can actually struggle to ventilate these patients if you actually haven't positioned them properly to actually get the flow of the airway properly. And then the same thing as when you are intubating as well, you will be anticipating that you're actually going to have a big tank that you actually have to do special maneuvers and pull the laryngoscope a bit higher so that you can have a proper view of the glottic opening. Another special cases, we have patients with cervical spine abnormalities. These cervical spine abnormalities, it could be from trauma. It could also be from some of our patients, like your Down syndrome, with cervical subluxations. Those ones would actually have limited movement of the spine. So you can't just do a jaw thrust and move their heads around. So we actually have to have someone, at least another person, that will do a jaw thrust for you. Or you use special techniques, like your special curved laryngoscopies that can actually give you a better view. And then we have another population of the patients with macropnesia, like your pure Revon syndromes. So those ones, the mouth looks small. So basically, your working area is a bit smaller than the usual patients. So it might be a bit difficult for a person that is not anticipating a difficult airway. Then they will struggle to intubate that patient, which might actually make them be more hypoxic and then run into problems. And then patients with midfacial hypoplasias as well. So these patients, the first thing you're going to struggle to ventilate them with a bag mask. And also, they tend to have the tongue that is posteriorly located, which can obstruct the airway while you mask ventilate. And also, it might be a bit difficult when you have to intubate the patient. And then the patients with cleft lip and palate. So those ones, you might struggle to secure and seal around the mouth to actually ventilate them with the bag mask ventilation, and also to intubate them as well. If you have a cleft lip and you need to secure the tube, it's going to be a bit flimsy. Whether you nasally intubate, depending on the extent of your cleft palate or your cleft lip, you might struggle to actually keep the tube in there. Besides the fact that you're probably gonna struggle to actually put the tube in as well because of some of the associated conditions. Supraglottic, infraglottic, and subglottic obstructions as well. This could be from an external. It could be also from the inside of the glottic airway that might cause you to struggle. If you're not anticipating those problems, you will have a problem to actually intubate that patient. So some of the things you need to get a proper history, a proper examination of the patients. So I think that's some of the information you need to relay when we call for ENT for help. And we can't just say, we have a difficult airway. So giving them a proper history on what patients are they coming to deal with, it actually makes them to think, do I need to bring something special to actually intubate this patient and help with the ventilation? So the proper history and examination comes into play in this kind of patients. Okay, and then the physiological features. So here, we actually look at mostly not just the airway that is obstructed or is difficult to intubate. So if you have a patient that desaturates too quickly, you need someone that can go in there, intubate without hesitation, without having any obstructions, or so basically you need someone with the skill to actually intubate that patient. So that's why we actually have to teach even the patient the people at the base to so that they can practice more about in terms of how to do a rapid intubation. The other thing would be with those patients with asthma. So if you have a patient with asthma who's hyperinflated, they have a prolonged expiration. These patients, the moment you start intubating them, they're gonna spasm. So if you haven't, they're gonna have a laryngospasm, they're gonna have bronchospasms, and you're gonna fail to actually ventilate this patient. So proper planning with these patients and how you're gonna set up your ventilation is very important, because you're gonna put this patient on the ventilator, you're gonna desaturate immediately, and then you're gonna think, is the tube really in, is it not in? But if you haven't done the proper assessment of your patient, it's going to fail. And then the other thing is the congenital and acquired cardiac diseases. If you're coming to intubate a child with a cardiac disease, always have to make sure you've optimized the patient and you have IV access. This patient will have an arrhythmia. The moment you start interfering with the airway, the vagal response, they get a bradycardia, you're gonna fully resuscitate that patient and you're gonna struggle with intubation afterwards. Patients with severe metabolic, whether it's from sepsis, is it hypovolemia, those are the things that need to be sorted out prior to even thinking that you need to intubate. So you have to stabilize your patients, because the moment you put in a tube, your vagal response, the patient will just crash. And those are some of the presentations that we get when you get a call from ICU. I was just intubating, the patient just crashed. So those are the very common reason why patients are being resuscitated at base immediately when people are intubating. So proper assessment, proper management of all the avoidable and treatable factors. Patient with trauma. So these are patients, so the traumatic injuries, facial traumatic injuries as well. So you have to be very aware. Patient with facial injuries, you're not gonna nasally intubate. So, and I know a lot of you have noticed, we like nasal intubations in ICU. And the main reason for that is to secure the tube. You know, our babies are always drooling, the tubes is not gonna sit well. So nasal intubations are always preferred, but in a traumatic injury, especially of the face, we have to avoid putting in the tubes in the nose. Okay, and then we have to identify the difficult airways prior to running into problem. So if we proactively identify the difficult airways, it becomes a lot easier to manage. And so we have many predictors of difficult laryngoscopies. In adults, we use the Malampati scores, modified Malampati. There's the higher mental and environmental distance, which are not well characterized in pediatrics. Because if you were to ask a 2-year-old to open their mouth, even if they were singing, the moment you start saying, open your mouth, they're gonna just keep it shut and you'll never see even a tooth. So that's why it does not work for our patients. Okay, so there's a different mnemonic, which is called lemons. This one has been widely used to predict difficult indirect laryngoscopy and intubation. Okay, so it's first one is you look. So the looking part is still part of your assessment. So you look for all the possibilities of a difficult airways, everything I had mentioned, especially in your anatomical assessment of your patient. And then you have to evaluate. When you're evaluating the patient, so you're looking at things like, you have to examine the patient. If this patient is having a stridor, you're already thinking about your upper airway obstruction, already anticipating what the possible problems are. And if you ask the mom a history, if this child had a runny nose about 2 days ago, now they're having a stridor, you know that you're gonna deal with a croup patient. And then if you have a patient who is wheezing, they're hyperinflated, you know you're gonna deal with a lower airway obstruction. So you always have to just evaluate your patient carefully before you start intubating. Malampati for the bigger kids, your 11, 12-year-olds, 2-year-olds don't work. And then you don't think about your obstruction. If you have a patient that is drooling, you know they're probably not able to swallow their own saliva, so you know your upper airway obstruction is gonna be a problem. Even when you see a patient that has a mass on the outside, you're thinking already, airway is probably distorted, so you're going to have issues if you have not fully assessed the patient. You still need to touch the trachea and see if it's not deviated first before you start using our maneuvers and put things inside patient's mouth. Probably assess first. And then obesity, also some of the problems that we are facing at the moment. The kids are looking bigger and bigger. 5-year-olds look very large. So some of these problems we're going to have in an obese patient, same way as an obese adults when you're using the Malampati score. And then also the neck. The neck, they have these short necks, so it's quite difficult also to intubate them. And then also other neck abnormalities like your spine subluxations, your neck injuries. And saturations is also put there in this mnemonic. Patients who desaturates too quickly are a part of your high-risk patients for failed intubations or failed ventilations. So you have to pre-oxygenate your patients, make sure that you are able to to ventilate your patient prior to even intubating them. See if we can actually ventilate them with a mask. Okay, planning for a difficult airway. So we don't have an airway team. I know we had this conversation with Smartly before, that we actually need to have an airway team that is gonna be your response team whenever there's a difficult airway. We all know what to do. There's someone in each unit that is part of that team. So some of the teams, because we're talking about babies, a neonatal unit would need to have an airway team, and that would include the doctors and also include a nurse as well, part of that airway team. Pediatric intensive care unit, which is us, and then the anesthesiology team also, they're always willing to come and help. But I think if we all form part of a team, we will all know in terms of crisis on what exactly we're supposed to do. And then of course, our ENT team as well. Okay, and then we look at management strategies. So these are basics. So we're going back to basics because I know we're very advanced now in technologies. We've been seeing a lot of first world things. But if you go back to basics, we're not going to lose our patients. So if we do effective back mask ventilation, we're not going to lose our patients. And even if that time you're calling for help, you just beg. You shouldn't be fidgeting with the airway. If you see that I'm struggling, this is a difficult airway, while you're calling for help, make sure you're able to ventilate your patient. According to the APLS and your pulse, you need to give about 20 to 30 breaths per minute for the pediatric population. And please make sure that you do the special maneuvers, your jaw thrust in the smaller babies, also to put the padding behind the shoulders so that you keep a normal pathway so you can have your glottic airway movement. And then the back, I've seen this in ICU during a resus. So we need to go back to actually teach each other how to actually hold that mask to have a proper seal. So the EC holding mask maneuver, or you have the two personnel technique when one person is holding and the other one will be doing the bagging. And then gastric decompression, because now we don't have a separate pathway from the esophagus. So this is part of the reason why you will struggle, even after you've intubated, to ventilate the patient if the abdomen is very distended. Okay, and then video laryngoscopy. So with video laryngoscopy, because it allows indirect visualization of your glottic opening by camera, which is located at the end of the laryngoscope, it's quite helpful for the visualization one, we need to start teaching our other colleagues as well, and also for evidence to say, was this really a difficult intubation or not? Because those are the issues that we will see in ICU. You're gonna find a patient, there was a struggle, it was a difficult intubation somewhere else, but when you look, there's so many injuries on that airway, but there's a leak when you're looking in the ventilator. So that's a direct video laryngoscopy is actually quite helpful. So we have standard and hyperangulated blades, and this actually improves the visualization of your glottis, but it does not translate to improved success rates. So this is a skill also. So we've tried to push for people to actually use the CMAC in the ICU, but they still struggle with the hand-eye coordination. They say that they can't really put the hand and then look while they're looking at the video there, which it's a bit difficult when you're starting. But I think as we get used to it, we're all gonna get it at some points, because this is where we are going. We're probably gonna do away with just the direct laryngoscopy. And it has been associated with longer time to intubate in some patients. This is also because of the anatomical challenges and also the skills. So practice. I think I can't stress that enough. And then we have some standard blades. That's one of them is there in our ICU. which is actually almost similar to our conventional Miller and Macintosh blades. Then we have the hyperangulated video laryngoscopies. So these ones are actually useful in patients with your spinal injuries that you can't really do a chin lift on them. So you need the hyperangulated. It's about, we have the 55 to 90 degrees, and it's quite useful in those type of patients. And then the bougie, the tracheal introducer, we hardly use it in pediatrics. That's when we've called our colleagues, and then they'll come with the bougie from theater. So it assists in blind intubation, and based on tactile stimulation of the angled tip striking the vocal cords. It's effective in adults, and it's less used in the pediatric population because of that tactile stimulation, which can be less pronounced, which is with the force, and you can't really feel that you've actually hit the vocal cords on those patients. They're very prone to actually having injuries, like your laryngeal and your tracheal injuries. So we try by all means to avoid those. And then supraglottic airways. We don't use this as much. In our ICU, we actually haven't had a patient that is just on a supraglottic airway. So this is a rescue airway commonly used in theater, as Dr. Cronje did mention. It doesn't completely isolate the trachea, so there is still a risk of aspiration. It is useful in anatomical abnormalities that interfere with the seal of your bed mask ventilation. So in patients like your cleft palate and your cleft lip. And then fiber optic bronchoscopy. It's not frequently used in the pediatric population for a few reasons. One, the skill set. Two, our tubes are very small. So to actually put if you're using the preloaded ETT method, it's actually quite difficult to actually remove the ETT from the fiber optic bronchoscopy. And there are a few techniques. So there's the hybrid technique where you're using the fiber optic bronchoscopy and the video laryngoscopy, or you can use a supraglottic airway, which can be a very useful rescue method. And also with that, you can actually use, instead of putting a suction on the suction catheter, you can actually use oxygen. And it helps when you're doing an intubation, because what you do is, if you suction, if there's like blood clots or there's even just secretions, they just stick on the camera. But if you're using the oxygen and you put higher pressures, you can actually push the secretions forward while you're actually intubating. So that's one of the techniques that we've actually had to learn about. And then the preloaded ETT one, which is self-explanatory, but it's actually better on the bigger patients because of the size of the ET tube and the scope. And then alternatives and modification to our rapid sequence intubations. So in a patient where you are not sure whether you're going to get the tube in or not, do not use neuromuscular blockers. If you know you're not going to be able to ventilate the patient, must ventilate the patient, you don't use a neuromuscular blockage. Using the sedation alone, things like propofol or you use ketamine. So those are the safest drugs that you can actually use for intubation. And this patient actually quite relaxed once you started using the sedation without the neuromuscular blockage. In case it has been used, you can actually use a reversal. And then there's the surgical airway option. So that's where our colleagues come in. So this is not very common in the pediatric population. In my time here as a fellow, I've actually seen one that had been done in one of the patients that was a difficult airway. So there's quite a few options: the needle thyrotomy, and then the percutaneous based one. And also there's the open surgical cricothyrotomy as well. So these ones that have actually been explained in the previous talk. Okay, so in conclusion of my topic, so in addition to the pediatric anatomy and physiology, some of these patients have specific risk factors for difficult airways, so that needs to be assessed prior. And then we have universal strategies, including optimization of oxygenation and bag mouth ventilation, should be coupled with identifying patients at risk and implementing patient-specific strategies. And providers should familiarize themselves with rescue methods such as the supraglottic airways, and planning is very important. So appropriate equipment, personnel, and the systems to access these critical situations. Those are the very important parts. If you forget anything else, just only remember this part. Thank you very much.
Thank you, Dr. McCarthy. Any questions?
Hi, I'm also from PED, so I really appreciate this talk. I just like to ask the question, sometimes we have patients with LTB group, and they have extremely difficult airways because it's very, very swollen to get that tube down. I've seen my colleagues, some of them using lignocaine, so lignocaine soaked gauze if you don't have an actual lignocaine spray, and putting that on the area to try and decrease the swelling and then pass the tube. What do you think of that practice? I'm sure it's not something that's very common, but it's something I have seen being done.
We actually do use it, but it needs to be in a very secure environment, like in theater. So usually if I have a group patient, I would prefer to intubate them in theater. So the lignocaine, we do use it, not only on those patients as well. For us who are doing bronchoscopies, we actually do use it quite a lot because our patients are actually more conscious. So just to relax the vocal cords, it's very useful. It's actually a practice that we actually have been doing as well.
Okay, thank you.
I would just make a comment. I don't think the lignocaine reduces any swelling. I mean, adrenaline, sure, or oxymetazoline, dulmetazoline, something like that, maybe. So I think the lignocaine just makes your larynx less reactive when you're intubating the patient.
Yes, yeah.
That's the main. It's a sensory block, not a vasoconstrictor.
Oh, yes, yeah, we use it for that reason as well. Thanks, Paul. Thank you.
Thank you. Thank you for the answers, Dr. Sheikh Kafur, who's the head of department here at Cardiothoracics. Pediatric surgery, right? Pediatric surgery. And thank you very much for giving up your time.
Okay, thank you, Dr. I know that the talk and the program was very labeled reflux, but I think this is more important because every day we get consults. We've got a patient needs a gastrostomy. That comes from ENT, plastic surgeons who want to do a patient with a cleft lip or with a Pierre-Robin sequence. The neurology wards are full of patients that have neurological things. And then also our GIT and our refluxes. And then we ask for investigations, and everybody says, oh, why are these people asking for these investigations? Why are we doing all these things? And hopefully this talk will give you some sort of insight on what we're looking at and why we are doing this in our patients. Okay, so the first couple of slides I'm just going to gloss over because I'm sure we all postgraduates over here. We all know about malnutrition and we want best healing for our patients. And if we don't take effect of and cognizance of the patient's nutritional status, we are going to have problems. We all know about poor wound healing, but we must also remember that if you have a malnourished patient and we're taking them for major operations, about going for lung destruction, for jaw destruction, that if you don't have these patients well nourished and you continue the nourishment during their surgical stay, these patients are going to end up having a problem. But these are just broad definitions. Nutritional, what is nutrition? Enteral nutrition? It's providing nutrition directly to the gastrointestinal tract by bypassing the oral cavity or using special formulas. You can give these even orally. Again, when is enteral nutrition indicated? And I think we tend to forget that in our surgical, especially our neonatal population, less than 3 months, if you're going to starve them for for more than 3 days, you're going to end up with malnutrition, you end up with problems. And when we do these patients, it might be a patient with, let's say, a neck mass, and you think, we can keep them on TPN for 2 days. We can go and do it theater, but we tend to forget that these patients have problems and long-term consequences that we have to be aware of and do something about. I'm not going to go into the wasting and everything. So these are our main indications for nutrition, for access for nutritional education. And I think the first one is disorders of oral feeding, abnormal suck and swallowing. Some of these patients come from ENT, but the majority of them come from the neurology wards, the CP children. Our patients with esophageal atresias and stuff like that. Severe gastroesophageal reflux disease, those are symptomatic with strictures and failure to thrive. Then we also see patients with severe feeding aversion disorders. Disorders of digestion and absorption, I think this is mainly what we see. Our patients with short bowel syndromes, our patients would have Hirschsprung's disease or long-spectrum Hirschsprung's disease that require nutritional support and nutritional access. Increased nutrient and metabolic needs like Burns patients. And then we have also a group of patients that are referred to us by our physicians in endocrine. In these patients where enteral nutrition is a key component of the treatment. These patients are the ones that have enzymatic deficiencies that require very unpalatable diets that are best given by a gastroscopy. Okay, I'm just going to skip this slide. We all know what enteral nutrition is and why it's better than parenteral nutrition. Then we'll go on and talk about enteral feeding access. For short-term access, less than 4 weeks, an NG tube or special feeding tube, nasal gastric feeding tube is sufficient. Where enteral feeding is required for more than 4 to 6 weeks, it is recommended that this patient should have some sort of enteral feeding device. And this is where we come into gastrostomies and jejunostomies. But that is the general consensus, because long-term treatment with nasogastric tubes have their own complications and long-term problems. And we're going to talk about how we assess these patients, why we assess these patients, what are the advantages of gastric feeding compared to post-pyloric feeding, our preoperative workup, enteral access, and the need for fundoplications in these patients. The one thing we tend to forget about is the parental perceptions. So a lot of the parents need a lot of psychological support. And when we have these patients, they're sent to the clinic, they say, patient needs a gastrostomy. Ask the mother, why did the doctor send you for the gastrostomy? It's going to make my baby better. And you tell them, it's sometimes quite painful trying to explain to a mother that by me doing a gastrostomy, his neurology is not going to improve. All I'm going to do is improve her life. And parents are very worried about not feeding you. You see, everybody wants to feed you. I mean, if you go home now as an adult and your mom is there, the first thing she wants to do is feed you. And they find it as a pleasurable activity. And it's important that we reinforce that when we're doing these patients with gastrostomies, that we're not taking this away, we're trying to improve the patient's condition and also the mother's condition, especially in our patients with neurological impairments. Because these patients, the parents spend hours trying to get some feed into these patients, and then they neglect the other children and they end up that. Getting teams, everybody here before has discussed teams, and I think, it's about time that we sorted out teams for these patients, where everybody knows their role and this thing. And I think the dietitian should be the primary focus of these teams, but also our speech therapists, patients with swallowing disorders. The nursing system, they need a support system. You're sending a patient home with a gastrostomy, they need to know how to manage this patient, how to clean it, how to look after it, when to change it, how to change it. And we are lucky that the industry does provide some sort of home visits for some of these patients, but it also depends on which tube we're using at that time, which tender the government is buying. Okay, and I think psychologists, radiologists need to understand what we're looking for when we're asking for investigations in these patients. And then the gastroenterologist or the surgeon is going to actually do the procedure. Again, gastric feeding is much better than post-pyloric feedings. Lots of times you get patients, especially from our intensive care unit, they say, yeah, if you've got this patient, shouldn't we feed this patient post-pylorically, giving continuous feeding? Gastric feeding is always better, especially if you're using it as chronic access. Post-pyloric feeding has very specific circumstances. Patients where their stomach is not available. So either it's not available by gastroparesis, severe reflux, and I think the only other condition we probably see is in patients with pancreatitis. So we don't want to stimulate the pancreas and we want to try to give them post-pyloric feeding. The disadvantages, they need placements for the infusion, they need infusion pumps. The placement is very difficult in these patients. They might require to go to theater, have endoscopies done, and stuff. And there's also an increased mortality in these patients. It bypasses all the physiological mechanisms that the patients have. So preoperative workup. This is a minefield if you read the literature. If you read some people, they say, patient needs a gastrostomy, take him to this thing, do a PEG. There's other people that tell you, let's do a swallow, let's do a 24-hour pH monitoring, let's do impedance studies, let's do manometry, and everything else. So we have to have a middle ground for this, and you have to understand why we're doing this. Because preoperative workup for patients that require chronic feeding, the main thing we want to know is, are they refluxing, or do they need another procedure in combination with their gastrostomy? I think the upper GI series is the commonest investigation used. It's important, it can pick up anatomical abnormalities in these patients. It can tell us about oropharyngeal swallowing. It can tell us of the presence of reflux. And also in our patients, it can tell us about things like distal obstruction or gastric outlet obstruction that might need to be addressed prior to doing the patient's surgery. 24-hour pH monitoring. So what we've done, I'll show it to you in the next slide, is probably the gold standard for looking for reflux in these patients. We have it freely available. It's probably going to be superseded by impedance once they sort out all the pediatric values, because it gives you a better indication of reflux. Nuclear medicine scanning, the so-called MILT scans that we do, I think they have a role, and it's mainly our role in our situation is in neonatal patients. So you can't take them down for barium swallows. You can't get a pH monitor. You need to feed them. And these patients, because you can scan them, the time of scanning, you can scan them the next day. So if they're refluxing, they're aspirating contrast into their chest, you can see it. If I'm taking too long, just let me know. Endoscopy, again, very controversial. Some people say when you're doing this, if you have a patient who needs this, always needs a scope. For us, a scope is an invasive investigation. For a child to have a scope in our setting, he needs an anesthetic. So there are problems of that, and we generally only do a scope if our findings are incongruent. So the swallow shows no, this thing they said, but the patient has got, if you look at him, severely managed. So you have to look for other pathologies in these patients. And then in those patients, it's important to do a scope before you do the operation. So we've evaluated the contrast study in our institution over a 2-year period, and we found that if you do contrast studies to assess reflux, it has a 62% sensitivity in upper GI series. In the negative patients that they didn't show reflux, all those patients have pH1. We found that almost half of those patients that had a negative contrast trial had reflux on swallow after. So for us, that means that when we're doing the gastrostomy for these patients need a concomitant mesenteric plication. Okay, so some of you all might ask, why don't we just do the pH monitoring rather than doing the contrast study? But it shows us importantly, it's a good screening investigation. It tells us whether they have strictures, whether they have any other problems that might require management. And then we go on to enteral feeding access, nasogastric tube, we don't talk about. Then talking specifically about gastrostomies and gastrostomies alone, I think I'm going to go into a bit more detail for those ones. So as I said earlier, gastrostomy is indicated for any patient that is envisaged long-term feeding. If you envisage feeding for more than 4 to 6 weeks, these patients require gastrostomy. So what type of gastrostomy? I think nobody, unless you're doing an open procedure at the same time, does an open gastrostomy, and it's been superseded by things like PEGs and laparoscopic gastrostomy. Another important thing is where to position the gastrostomy. Okay, the ideal place is probably about here, if you can see there. But if you're going to use the stomach later on for a conduit for a patient with esophageal atresia, you should always keep these things in your mind. So it's probably better if you do it more towards the left. So you can probably use that later on as a conduit. PEGs have only been around for about 40 years, and a lot of people use the term interchangeably when they talk about percutaneous endoscopic gastrostomies. It has the main advantage, especially in adult patients, that you can do this as an outpatient procedure under sedation without a general anesthetic. Okay, the disadvantages, especially in the pediatric patients, that they require anesthetic already to do the scope. You might position these things inappropriately. So if you look at this patient looking at the scope of the ear, you can easily catch the colon in between and cause a gastric colon fistula. Some patients who have big livers, remember children have very big livers, and you might damage the liver trying to do a big. So we tend to do laparoscopic gastrostomies in this patient if they require. So we hardly ever do PEGs because a lot of our patients have upper airway problems and strictures and stuff. Laparoscopic gastrostomy is the preferred method. I think there's lots of studies that show that it has less mortality than PEG placements. And the main advantage is that you can visualize where you want to put the gastrostomy. It's a single procedure. Remember, if you do a PEG, you have to take out that PEG and change it to a normal gastrostomy tube. So which for a child means going for another anesthetic, having another endoscopy, take out the tube from the stomach and then put in a PEG once your PEG has matured. And it also fixes the the stomach to the anterior abdominal wall so that you don't get dislodgements and leaks in these patients. So this is also a study, and I'm just going to show you a little video if it plays. So this is also a study where we did patients where we've done primary gastrostomies in these patients with a very, very low complication rate. So we just use a 2-port technique. You can see the 2 ports over there. And our complication rates for granulomas was less than 8%. We didn't have any major complications with these patients, any tube dystostomies. So you identify where you want to put this, the gastrostomy. You put in your suture and you grab the stomach, so like that. And then you do everything from the outside after that. And this works well. And even if you have to do a Nissen, we do these gastrostomies, and it's quite counterproductive for us to do. Previously I've seen people do Nissens and then they do a peg after that and pull this peg right through the uniform Nissen. So obviously causing disruptions. So this is the completed pegs in these patients, and they do quite well. When we're talking about gastrostomies, we also have to be aware of the complications. They are common. The listed complications or major complications are usually less than 5%, but minor complications occur up to 70% of patients. So you should be very aware of these patients. They do have complications. The majority of them are minor, like some granulomas and overgrowth tissue that can be managed locally. And that's why these patients require follow-up, especially home visits, because these patients are generally very sick patients that don't need to come to hospital. And if you look in KwaZulu-Natal, we paying millions of rands or billions of rands in litigation for these CP children. And the government has actually set up 3 centers where these patients are going to be managed. And the best place to manage them will be from those centers and probably to the home. This shows you one of the complications if you need gastrostomy is unattended. This is where they kept on, and this is basically a necrosed stomach that's protruding. So there are complications that we have to make the parents aware of. The need for fundoplications, I think for us, we use a very selective approach in these patients. If we've proven reflux preoperatively for chronic this thing, we always do a Nissen with it. For patients we don't, we usually do the gastrostomy, and if they do develop reflux after that, we would then do a Nissen as a secondary procedure. And using the selective approach, I must say that in patients that we do a gastrostomy, less than 10% of the patients will require a Nissen afterwards. So by selecting them out, we're not doing major surgeries for them in the initial and by not doing the major procedure, and then we can go and do it later on. So, as I said earlier on, and I'm going to stop again, there's many controversial issues in gastrostomies. The role of pre-procedural investigations, need for fundoplications, PEG versus RIGS, radiologically image-guided gastrostomies, laparoscopic gastrostomies, ongoing assessment and education, and obviously the ethical issues involved in this patient. Well, this talk is just about chronic access. Acute access is a completely different topic. Majority of them you can just do nasogastric tube and you get away in the majority of these patients. But we do see those patients, the ones with esophageal atresia, the patients with caustic ingestion with a total burn of esophagus. And in those patients, the primary listing is a laparoscopic gastrostomy. So I'm going to stop there, and if you have any questions or comments.
Thanks for the lovely talk. Just two questions. One about CP children. What sort of percentage do actually need pegs, and what criteria do you use for when to insert a peg on these CP children?
Actual percentages I can't tell you. And I can tell you that we get referred about 3 to 4 every week. We do about 1 missing a week, so we're doing about 50 a year. So that's quite a lot. So the problems are, the main problem is when you're assessing these patients, it's very important to speak them up. As I said, they get a very poor impression of what you're trying to achieve in these patients. A lot of them, when I speak to them in the clinic, and I tell them, this gastroscopy is not going to do anything for your child's neurology. And they say, the doctor said, and a lot of them actually back down. So we don't chase them away, but we tell them, I would not even start investigating the patient if the mother is not being educated properly to understand what we want to trying to achieve in this patient. So actual percentage I can't say, but I think the majority of them in the long term are on that some sort of need. It depends, we're getting more and more younger patients, but we also get a cohort of patients that are much older. So where the problem is.
What criteria are you using? Is it a dietitian's assessment? Is it aspiration issues?
I think it's mainly it depends on what symptoms they have. So if it is the dietitian, these patients have failure to thrive, they're having problems, they're having, and the other main thing is the parents' perception. So if a mother is taking more than 4, as I mentioned in one of one, is taking more than 4 hours to get a meal into a child for a day, those patients shouldn't be referred for gastroscopy or assessment.
More than 4 hours in total, or
More than 4 hours in total for the day. Any other question?
Sorry, one more from you. With regards to pegs and reflux, I know you said you'll do your assessments, but I mean, there is a degree of reflux that would require an certain with the peg.
So for us, if a patient has reflux during his assessment, then we will do a listen and peg at the same time. If he has no reflux, according to the list, we use the DBS score. If the DBS score shows that he has no reflux, then we won't do a peg. We won't do a listen, we do the peg. We say peg, but we will do the gastroscopy and then assess him and take him from there. Because when you dream a gastroscopy, you now also alter the effects. The whole anatomical structure. So by pulling the stomach there, you making the angle of his nose, so you're increasing the patient's system of getting reflux. Also now they're giving bolus feeding. It's what we want them to do. And the parents maybe start trying to give too much. You give them too much feed, they're going to start doing reflux.
The next, we can start with some cases, case presentations. So Dr. I'm going to hand over to Dr. Satori, who's our ENT consultant here at Abu who's heading up our Paediatric Airway work at the moment. Thank you.
Good afternoon, everyone. So the cases that I'm going to go through are cases that we had presented to Prof. Shine last year, and we've done some of the cases with him last year. So our first case that we had done was a 14-year-old male with a background history of having a stepped neck at 4 years of age, and ended up with glottic stenosis, suprastomal stenosis. He had had multiple previous airway surgeries, but unfortunately we couldn't decannulate him with those surgeries that we had done. So the case was discussed with Prof. Shine, and then we ended up doing a post-single stage tracheoplasty and a laryngeal AP graft and harvesting. In terms of his findings intra-op, we noted that he had an intraretinoid scar band, he had a normal subglottis, but he had a suprastomal scar tissue with skin that was prolapsing into the stoma. Unfortunately for this guy, although we had hoped that it was going to be a single stage and then was going to be extubated and fine afterwards, we had quite a stormy ICU course where the plan initially was to intubate for 5 days and then for extubation after 5 days. So when we took him for his DLT and that planned extubation, we found that he had pyelodematous cords and supraglottis. There was narrowing at the suture line, so there was a stenotic segment at that suture line with granulation tissue at 12 o'clock. And then it also looked like where the tube was sitting, now it had caused like mucosa to actually lift up from the trachea. So we then reintubated under direct vision and sent him back to ICU. It was then during that period where he was noted that he was having subclinical seizures. He wasn't responding to sedation, so his sedation needed to be changed from Presidex and Propofol, and we had quite a lot of issues. So we then planned for an open tracheostomy, so for a repeat DLT and then for an open tracheostomy, which then bought us time that it could be discharged from ICU. So he was discharged from ICU after that, and then we then had to take him back multiple times just for EUA to inject with triamcinolone and for balloon dilatation. Prof. Shine calls it TLC, so we needed to take him for weekly TLCs. So we eventually decannulated him in March of this year. This is how his airway looks now. So he's got quite a nice, so this is where the slide tracheoplasty was done. So he's got quite a good airway. He's been able to play soccer. They're really quite happy. Like to think that for the past 10 years, from 4 years of age, basically for the past 10 years, he was trachea dependent. Yeah, so he's really quite happy. So that's one of our first cases. I'm not sure if there are any questions. Okay, I'll move on to our second case, which was also a single stage. So he's an 8-year-old male, now 9, with a background history that at 40 months of age in 2017, he had presented with upper airway obstruction symptoms, where it was noted to have retropharyngeal mass. On biopsy, it was noted to be a neuroblastoma. So he had been tracheostomy dependent since then. So on EUA, we noted that he had subglottic stenosis, but which was more of the Cotton-Meyer one. So it actually looks worse on this picture than it did look when we did the DLT. And we noted that he's got suprastomal stenosis. You can see with the bottom picture. So this was a view through the stoma where you can see inferior to that stenotic segment is the trachea and superiorly is the subglottis. So we then did a slide tracheoplasty as a single stage. He is one of the cases who woke up really just crying, so anxious and crying for his tracheostomy. He wasn't happy, he kept on asking for it in post-extubation. Otherwise, it's done really, really well. Mom is really happy. So she's just complaining that he's very hyper. Otherwise, she's quite happy with the progress that is actually made. Yeah, so this was our second case. Our third case was a 11-year-old female with a background history of DeGeorge syndrome with a tetralogy fellow who had complete glottic stenosis due to prolonged intubation. And she had also been tracheostomy dependent since 2012. I think she's 12 years now. She had also had laser surgery between 2017 and 2019. So when we did the DLT with Prof. Shine, we found that she had fixed arytenoid joints, she had complete glottic stenosis, she had scarred irregular cords, there was no cricothyroid membrane, we thought which was in keeping with the DeGeorge syndrome. She had atrophic right strap muscles and also had features of cartilaginous stenosis. So those are the pre-op pictures that we had actually taken at the clinic. So we had then done a laryngotracheal reconstruction with an AP graft, where she did really, really well. We had done her as a single stage, so she had gone to high care post-op with the tracheostomy. So this was one of the initial EUAs post-removal of the stent, where we then took her for TLC as well a few times just to remove some of the granulation tissue. Otherwise, she had quite a good airway. You can see that the graft was slightly prolapsing into the airway, but she had a relatively good airway. And there was a bit of suprastomal granulation tissue, but the airway was adequate for her. So we were able to decannulate her. So she's one of the kids who was now in that twin age, and she was literally just walking around with a bent neck, trying to hide the trachea. So there was quite a lot of psychosocial issues as well at school. But we were able to decannulate her, and she's been quite happy, and the parents have been very, very happy with the progress as well. Our next case is an 8-year-old, I think she's 9 now, with a background history of subglottic stenosis due to prolonged intubation, post-transposition of great arteries repair. She had had previous multiple laser surgeries, so we had then assessed her and done a double-stage LTR with an anterior and a posterior graft, where we then removed the stent in February. So on EUA, she was noted that she had bulky swollen edematous larynx, which was collapsing into the airway. The true cause were edematous and not easily recognizable. She had minimal suprastomal granulation tissue, but she had a reasonable size airway except for the collapse. There was no overt stenosis. We had then decannulated her. I had a video, but it didn't want to play. So we had then decannulated her. They were happy for a few days, but mom came back a few days reporting that she's fine during the day, but it's only at night where she obstructs when she's asleep. We were then forced to insert like a smaller size tracheostomy. She's planned for a supraglottoplasty because we noted that her arytenoids were falling over the glottis. So it's more like a supraglottic issue, but a glottis and a subglottis, she's got an adequate airway issue. Of note is that she does have a history that was noted previously that she had laryngomalacia as an infant. I'm not sure if there are any questions for that. Okay, and then our next case is a 16-year-old female with a background history of a previous traumatic brain injury secondary to an MVA. So where she was, had tracheostomy inserted in 2010 for prolonged intubation. She had also had multiple airway surgeries. We then did an anterior and a posterior cricoid split last year and had to open the glottis because she had complete glottic stenosis. Of note is that with her now, we didn't complete the surgery, so we couldn't really decannulate her. She was able to vocalize, but we couldn't decannulate her. So she was then planned for an anterior and posterior laryngotracheal reconstruction with an anterior and posterior graft, of which a subglottis was fine, but the main pathology was now more in the glottis. So she's had an anterior posterior cricoid split done currently, now it was done on Tuesday. She's currently in the ward doing well. So we've done it as a double stage procedure because we're just trying to buy ourselves time, also due to other shortages like ICU shortages post-op. So we prefer to do it as a double stage for now. Otherwise, she's doing well in the ward currently. These are the pictures where we had done that posterior cricoid split and opened the glottis. Of note, you can see that she had that anterior glottic edema, mucosal edema. So it was difficult. Oh, okay. Yeah, so otherwise she's done really, really well. So she's currently in the ward now. Our next one is a 9-year-old male with a background history of prolonged intubation with multiple level airway stenosis. Initially was assessed as a congenital subglottic stenosis. He required a tracheostomy from 2015. I think initially they suspected that it was like a subglottic stenosis and a suspected tracheomalacia. Otherwise, he had also had multiple previous laser surgery and dilatations, of which at our previous visit, we had just done, because he had quite a lot of edematous mucosa, so we had done a biopsy, just wanting to exclude eosinophilic esophagitis, and we'd done an ANCA, ANA screen, all of which all were negative. And his contrast swallow, no reflux was noted. So we've recently taken him at this visit now. So you can see the previous picture where he had complete subglottic stenosis. We've taken him for a cranial resection currently, and he's still in ICU. He was done yesterday, so he's still currently in ICU. He was done as a single stage. Okay. And then this is one of our cases from a private, so a 9-year-old male who had a background history of bilateral vocal cord palsy with a tracheostomy done on day 3 of life. At 5 years of age, he had a right laser cordotomy and partial arytenoidectomy done, but of note was that there was difficult access during surgery. A few months later, he had bilateral laser posterior cordotomy, so he had laser surgery. So at his previous, at Prof. Shan's previous visit, which was last year in November, so we had done excision of the glottis, and we've done a posterior cricoid split, where it had multiple balloon dilatations and injection with triamcinolone. And today we'd actually just done an anterior and posterior cricoid split with a rhinotracheal reconstruction. Yeah, so we're happy with the way the airway looked. This was how the airway looked with the multiple dilatations. You can play the video for me, please. You can see in that posterior where that posterior cricoid split had previously been done. So it looked like most of his pathology was like a posterior commissure stenosis. Yeah. Okay, the second one as well. Yeah, so so we've done a laryngotracheal reconstruction today, so we're hoping he's going to do well as well. Okay. And then one of our last cases was a 6-year-old male with a background history of caustic ingestion, which was complicated by pharyngeal stenosis and esophageal stenosis. This was in 2021. He had had a gastrostomy done and had multiple pharyngeal dilatations, with laser release of the epiglottis and epiglottopaxy. But of note that he kept on having recurrence of the stenosis. You can see in that picture, on that superior picture, where you can see that there's that pharyngeal stenosis and there's that lumen. And you can see with the bottom picture where you can see the cords just directly below that lumen in the pharynx. So we had done a pharyngoplasty. He had actually decannulated himself at home in April of last year. So we had done a pharyngoplasty, of which it was quite a challenge to intubate him in theatre, and had been taken to ICU where there were issues with decannulation in ICU. Otherwise, he required repeat surgery because of stenosis again. So this was one of his swallows that were done. So it is swallow, you can see with the swallow, with that airway where the epiglottis was part of that stenotic segment. So he had micro aspirations. You can see that swallow that was done. So we then discussed this case with our pediatric surgery team and discussed with our plastic team, of which the plan was that he might need, because there was quite a fibrotic tissue, it may be difficult to do any any anastomosis in that area, because the tissue is actually quite fibrotic and not healthy at all. So he was planned for a flap by the plastics team. So he's currently being managed by the plastics team. I think that's my last case. I'm not sure if there are any questions.
No questions. Thank you very much for all of those who came today to listen, and for those that helped present as well. We did cut off Shane a bit earlier this morning, or this afternoon, or midday. I don't know if there's any chance to take any questions. So are there any questions for Shane? We just talked earlier today, and is there anything that we want to hear? It's been a long run, because I don't think we've had a 4-hour, no break, no nothing. Some of you might be bursting for the toilet. Anyway, thank you very much for joining us today, and we'll see some of you tomorrow. Okay. Let's see that.